We are waiting for someone.
Sir, we are starting, sir.
A cheerful morning to one and all present here on the CME. It's a great privilege for me to welcome the dignitaries, renowned speakers, respected delegates for the inauguration of this virtual CME on reproductive physiology bench to bedside. Today, we are going to get enlightened on the pathophysiology of reproductive system with an emphasis on the infertility, a global health issue affecting millions of people in the reproductive age group and strives for an effective solution. Hopefully, this CME program will effectively address upon the issues we face globally and give us an idea about how we gonna encounter this situation and issues. Before that, a quick disclaimer. This program is live streamed and being recorded for academic purpose, and I request the participants to kindly mute their devices to make the program smooth and fine. Due to time constraint, kindly keep your queries in the chat box, which will be addressed. It's customary to start an event with lamp lighting ceremony. Let us have a virtual lamp lighting lamp.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
I pay my salutation to the light, which brings us auspiciousness, prosperity, good health, wealth, and destruction of the intellect's enemy. Then over to Kalyani.
I welcome Sri Lakshmi M. Nair, a first-year MBBS student, for the invocation song.
कपित्तजम्बू फलसारभक्षितम् मासुदं शोभिनाकारम् नमामि विघ्नेश्वर
Thank you, Sri Lakshmi. That's an amazing performance. I now request Dr. Lakshmi Chatia, Professor and HOD of Physiology AVMC and Organizing Chairperson of CME, to deliver the welcome address.
With the divine blessings of Almighty, showers from Founder Chancellor, benevolence of Chancellor, and Madam Chancellor. Good morning, respected Dean Sir, Dr. P.F. Couture, esteemed speakers of the day, Dr. V.N. Mahalakshmi, Health Professions Education, Dr. Vishnu Bhatt, Director Medical Research, Dr. K. Jayasingh Sir, MS, Dr. T. Rajan, Vice Principal, Dr. Annachalam, Vice Principal, Student Affairs, my colleagues from AVMC and other medical institutions, and dear delegates, a very good morning to one and all. On behalf of the organizing committee of the CME on reproductive physiology, bench to bedside, it gives me immense pleasure to welcome you all to the CME. We, the Department of Physiology at AVMC and Hospital, are honored and delighted to host the CME. This CME is the result of collaborative and synergistic efforts of the Department of Physiology, Arunipur Medical College, Srishti Assisted Fertility and Advanced Laparoscopic Center, Pondicherry, and Jindal Hospital and Test Tube Baby Center, Meerut. This CME has a distinction. Can you please mute? Okay. This CME has the distinction of bringing together resource faculty from 2 states and delegates from all over the country for a vibrant and intense exchange of views, knowledge, and experience on reproductive physiology. We are honored to have our Dean, Dr. P.F. Couture, sir, highly enthusiastic, perfectionist, and a man of principles amongst us. His encouragement and support is unparalleled.
Ma'am, you are unmuted. Please unmute yourself. Ma'am, you are muted.
So we are honored to have our Dean, Dr. P.F. Couture, highly enthusiastic, perfectionist, and a man of principles amongst us. His encouragement and support is unparalleled. I extend a very warm welcome to you, sir, on behalf of the organizing committee. Welcome, sir. I bid a very warm welcome to some of the brilliant minds of the country, our renowned speakers, Dr. Sebanti Das, Dr. Shashikala from Srishti, and Dr. Sunil Jindal from Jindal Hospital, Meerut, my batchmate from Maulana Azhar Medical College, who took out their valuable time and joined us today to share their expertise and wisdom with us. We are honored to have you all with us. Welcome. We are delighted to have the gracious presence of Dr. V.N. Mahalakshmi, Dean HP, who is always glad to help. Very warm welcome to you, ma'am, on this occasion. The organizing team also takes pride in welcoming Dr. Vishnu Bhatt, Director Medical Research, AVMC, is greatly benefited by Sir's research capabilities and passion. Welcome, sir. We heartily welcome Dr. Jayasingh, Medical Superintendent. His untiring efforts during pandemic is worth the praise. Welcome, sir. I also welcome Dr. T. Rajan, Vice Principal, for his unstinted support. Welcome, Dr. Rajan. And not the least, I also welcome Dr. Annachalam, Vice Principal, Student Affairs. Dear delegates, as Chairman of the CME, I'm delighted to welcome you for the CME and guarantee that the CME will be productive and worth your precious time. We would be delighted to have your suggestions and questions at the end of the event. Enjoy the event. Learning is not attained by chance. It must be sought for with ardor and diligence. This was told by the advisor and wife of the second president of US, John Adams, and also the mother of the 6th US president, John Quincy Adams. Thank you very much for joining us today. Welcome once again. Thank you.
Thank you, ma'am. Now I request Dr. Gopinath, Associate Professor, Department of Physiology, AVMC, Organizing Secretary of CME, to introduce the CME.
A very good morning to one and all present here in this August gathering. I feel privileged to give introduction to CME on reproductive physiology bench to bedside. While other systems in the body which work continuously to maintain homeostasis for survival of the individual, the reproductive system ensures survival of the species. It's characteristic of all living things on earth, and they reproduce or produce offspring, and humans are no different. In this regard, we are happy to host this CME that will not only focus on physiological aspects, but also the clinical correlates associated with it. Although the reproductive systems of the male and female are different, they are structured to function together to achieve internal fertilization if the couple wishes to pass on their genetic inheritance. And it is very essential to know about the hormonal milieu, which occurs normally in both male and female reproductive system. And this reproductive function is majorly affected in every one of us due to stress in our daily-to-day life. And we medicos always ignore and more on with our busy schedule. And this is one of the reasons there is occurrence of many infertility problems. A lot has been happened over the years in assisted reproductive technology to treat infertility and make this a reality for people who would be able to have a baby otherwise. Globally, infertility affects about 50% of the couples of reproductive age group, and 30% of the infertility cases are from males, and 30% can be attributed solely to the females also. Although male infertility contributes to more than half of all cases of global childlessness, infertility remains a woman's social burden. So today's CME will address all these burning issues. Very happy to give an intro to the speakers. Our first talk will be there are 5 speakers today. First talk will be Dr. Jyoti Mary Fula on hormonal milieu and reproductive functions. And second talk will be by me, role of stress on reproductive functions. And third talk will be in vitro to vivo, embryology storage and transfer by Dr. Shabanti, Srishti Fertility Center. And next talk will be fertility, male functions, subfertility on male functions by Dr. Shashikala from Srishti Infertility Center. And last talk will be in the afternoon session by Dr. Jindal. Dr. Jindal on subfertility on males. So today, this CME will be going to be a great academic feast for all the attendees and participants. Thank you all.
Next, I welcome Dr. P. F. Kotur, Sir Dean, AVMC, to give presidential address.
You are muted, sir. Muted.
Yeah. Very good morning to one and all over here. I'm indeed, as head of the institution, I'm privileged to be a part of this wonderful CME that has been organized by the Department of Physiology in collaboration with the Srishti Assisted Fertility and Advanced Center here in Pondicherry. Now, I must congratulate Dr. Lakshmi Jatia and her team for having chosen this burning problem, as said by Dr. Gopinath now, burning problem of the globe, wherein the infertility is a kind of a disease affecting both a male and a female, which have its own many effects. So I must congratulate for choosing this problem on the AVMC platform to disseminate the knowledge about that. It's a wonderful thing they have done. And I also must make a prominent remark that our Department of Obstetrics and Gynecology is prominently absent here. So I don't know, they should have been with them, their collaboration, they also should have been a part of it. I don't know where was the lapse, I do not know. But anyway, that is one remark I must make at this platform. And I especially welcome on behalf of our management and on behalf of our university, Dr. Sevanti, Dr. Shashikala and Dr. Sunil Kumar. Sunil Kumar, I am told, from Delhi, I think he must have, or Meerut. Yes,
Merit, sir.
Professor Jacques Kalia. I especially welcome all these resource persons for having spared their time to be a part of this CME. And of course, our local talent, Dr. Jyoti, Dr. Gopinath, Dr. Sushmita, Dr. Lakshmi, they are all over here. And on this occasion, some random 2-3 thoughts come to my mind. I won't take much of time because already we are running half an hour behind the schedule. First thing is, being an anesthetist, I used to anesthetize. I remember almost 2 decades back, the patients who were coming for artificial reproduction. We had a ARC established in our hospital. I'm talking about almost 20 years back. ARC was new, a new department, a lot of investment, embryologists. Our team was quite good. And now it's quite doing very well. And, our job used to be restricted only to giving some the thiopentone or the propofol and kind of that kind of a thing. But the remaining thing was all quite, we used to have some kind of such a new exposure. That's what is my limited exposure to that ARC. And now, this, I already said that this is the disease, it can be treated. Many of the causes for this disease of infertility can be treated, which is affecting sizable number of the population across the globe. And both male and female, both are partners. Unfortunately, our wrong notion that whenever any infertility is there, a female is blamed more than the male. That is one, that is slowly disappearing now. Now, I just and a lot many awareness, lot many training are very much required for this. And with the advancement in science and all, a lot many theoretical theory or therapeutic advances have come, starting from artificial insemination or to test tube baby, those kind of things are all over there. Along with the advancements in technique and the iatrogenic problems also will be there along with that, that also we have seen. Now, in a lighter way, I just like to conclude my thoughts. Even the films have been produced to disseminate the information about the artificial, this what you call the treating infertility. What I recollect is, of course, a recent one. Then two husband and wife, go for approach a center for infertility, and the gynecologist, what he does is, she crosses somebody's sperm in his wife and his sperm in somebody else's wife. And one was incidentally as a Punjabi Sardarji. And you can imagine the hilarious circumstances following that. And of course, one thing was, it has a psychological and social aspects. It was giving in a hilarious way, very good message for that. And that is one thing I must say. And recently, just a couple of days back on Netflix, I saw one more. The surrogate mothers, when American couple comes to India and they hire one good dancer who had a healthy body and all, and the center, the infertility center gives a wrong message that the child has got an anomaly, and both husband and wife, they disappear from the scene, and this girl is left to herself with that somebody else's baby. And it was again a message is given.
Mimi,
so
sir.
These something come
The
to
movie
my
name
mind.
was
And
Mimi.
of course, sorry,
Mimi.
Yeah. I'm so these things are that means including the doctors, every one of us have got a role to play in clarifying the doubts, clarifying the wrong notions, those are harboring the minds of the people, and can be treated ultimately with a good intention. So with these few thoughts or remarks, I really congratulate all and congratulate the department and welcome all the participants, resource persons, and my colleagues, Dr. Jay Singh, Dr. Bhatt, Dr. Mahalakshmi, HODs, all. Thank you very much. I am done now, Dr. Lakshmi.
Thank you, sir, for your insightful words. Now I request Dr. Vishnu Bhatt, sir, Director Medical Research, AVMC, for the felicitation address.
Respected Dean Professor Kotur, Dr. Mahalakshmi, Dean HPE, Dr. Jay Singh, our Medical Superintendent, Dr. Rajan, Dr. Arunachalam, our Vice Principals, the team led by Dr. Lakshmi, the organizing team, and all the resource persons who have gathered in addition to the people who participated. See, reproduction is such an important aspect. By the number of people who are participating itself, we can understand It is a major issue. Those who have children do not understand the problem, but those who do not have children, as Dean said, it has a lot of psychological and social impact on them, and it is a very serious issue for them. And in our mythology, if you see artificial reproduction and surrogate parent, all these have been described, but it was looking more like a dream or a story till now our advances in science made it real. So reproduction physiology, reproduction medicine, everything has to be integrated because one single department and few people cannot work on this field. So it requires, as Dean said, obstetricians, it requires urologists or surgeons, preclinical like physiologists, anatomists, and geneticists, in addition to many other people who may need to. And surrogate parenting also is a major issue. And just like a kidney transplant, it is going on in the big cities in a big way. There are ethical and moral issues in these things. So we have to be very careful in these issues. But I'm sure mainly this is being organized by physiology department. They are more concentrating on the technical aspect of it. So I'm sure that all participants will be benefited, and it will continue with another program with the multi-speciality approach, so that it will become more complete. I'm sure that it will be covering most of the topics because I was going through the program, more comprehensive, and I'm sure all participants will be benefited. I wish you all the best. Thank you very much for making me present here. Thank you very much. Thank you.
Thank you, sir. Next, I request Dr. V. N. Mahalakshmi, ma'am, Dean HPE, for the felicitation speech. Over to you, ma'am.
Yeah, thank you. Good morning, everyone. I especially I note with happiness I'm meeting Dr. Shebanti virtually after a very long time. Hi, Dr. Shebanti, and good day to all the dignitaries present, as well as to the students who have joined in large numbers, as well as delegates from other colleges and from the Physiological Society of India and all that. It's a very nice topic. Everybody told you about the importance of the first phase part of the topic, reproductive physiology, why it is important and why reproduction is a, because as this thing, but I thought I will tell you about this bench to bedside. How do we translate research in the laboratories into what actually can be used by people on a everyday life, right? So translating from basic science research into clinical practice guidelines takes a lot of effort from people, and we need continuous input because as our understanding of basic physiology, basic pathophysiology changes, so does our clinical practice. How we can incorporate this guidelines for best outcomes for our patients. So it is very nice for physiology department, instead of talking only about hormones, physiology and things like that, to involve clinicians also into this thing and say, tell us how these information, what we have generated in the laboratories can be used in everyday practice for the benefit of the people. As said, no, from bench to bedside, that is the key in that, and cross pollination of ideas, because we are talking in reproductive parlance. So that is, I think, what we need to do. This cross pollination is very good, and it will help us to generate new ideas, new focus areas for research, and new ways in which we can utilize the existing knowledge. So that way I'm quite happy with this CME. And I hope that you'll all have an academic feast today, enjoy the presentations, and I wish you all the best. Thank you very much.
Thank you. Thank you, ma'am. I request Dr. Jai Singh, sir, Medical Superintendent, for bless us with the success of CME. Over to you, sir.
Thank you, Dr. Naresh. Am I audible? Yes. Good morning to one and all. Beloved Dean, Dean HPE, Director Research, Vice Principal Academics and Vice Principal Student Affairs, speakers of AVMC, guest speakers who will be giving their talk in the afternoon session, organizing chairman, secretary, and the organizing committee members belonging to the Department of Physiology and IQSC, esteemed delegates who are now online for this CME on reproductive physiology. At the outset, I sincerely thank the organizers for giving me this opportunity to felicitate in the CME on reproductive physiology from bench to bedside. Next, I would like to congratulate the organizers for choosing this topic, a very essential topic to understand, especially in the era of mushrooming of infertility treatment centers throughout the country. It has been estimated, as Dr. Gopinath told, estimated that 12 to 28% of the couples experience involuntary childlessness. Male infertility is responsible for about 20 to 30% of infertility cases, whereas 20 to 35% are due to female infertility, and 25 to 40% are due to combined problems in both. As such, around 10 to 20% of the cases, we are not able to find out any cause actually. The consequences of infertility are manifold and can include social repercussions. I was not having any issue for about 3 years. We were worried, and more than that, my parents, her parents, all were worried. We could not attend any family function. We were feeling, we were very much, avoided in many functions, family functions also. So the repercussions and the personal sufferings in Indian community is a lot. Advances in associated reproductive technologies such as in vitro fertilization, of course, offer hope to many couples nowadays. But at the same time, medicalization of infertility also causes emotional distress in the couples, especially for the females in the Indian community. Patients with one treatment failure face significantly higher levels of anxiety, and patients with the two failures experience more depression compared with those without a history of treatment for infertility. Again, infertility have other psychological effects also. Partners may become more anxious to conceive, which can cause sexual dysfunction also. Marital discord often develops. Emotional stress and marital difficulties are greater in couples where the infertility lies with the man. In many cultures, inability to conceive bears a stigma, especially in the Indian community. A degree of rejection may cause anxiety and disappointment. These are several ethical issues. There are several ethical issues also associated with infertility, and its treatment. I'm happy the Department of Physiology and IQAC has chosen a very interesting and useful topic for the CME. I wish a grand success of the CME. Thank you one and all again. Thank you. Over to Dr. Naresh.
Thank you, sir. So, without any further ado, let's embark on today's proceedings. The first speaker of today is Dr. Jyoti Mary Fula. I request Mrs. Hemalata ma'am to introduce the speaker.
Morning to one and all. It's my pleasure to introduce first speaker of today's CME, Dr. Jyoti Mary Fula, Assistant Professor, Department of Physiology, Arupanavid Medical College and Hospital. Madam has completed her UG from Sri Venkateshwara Medical College and Hospital and did her MD from JIPMER. Madam has got a teaching experience of 4 years and has the 12 publications in both national and international papers. Madam has have the research interest in the reproductive physiology, genetic physiology, and cardiovascular physiology. Madam has also received 3 awards in the best paper presentation. Over to you, madam.
12 publications. Clear.
A very good morning, one and all. I am here to give the introductory talk of today's CME, that is the basics of hormones in reproductive physiology. This is the basic physiology. I hope this will be useful for a very good number of UG students who are part of our audience. And we also have many legendary physiologists in this forum. In the presence of them, I'll try my level best to render justice to the topic given. And before I share my slide, I would like to thank the administrative heads, head of the Department of Physiology, and my senior colleagues for giving me this opportunity. And my topic for today is hormonal milieu in reproduction. And I'll be dealing with the hormones regulating female reproductive system first, followed by the male reproductive system. We all know that female reproductive system is a very strictly governed clock which is regulated at various levels in the hypothalamus, anterior pituitary, ovary, and other reproductive organs. So it is very crucially regulated by various hormones at all these levels. So we'll be dealing with this one by one. First, let me start with hypothalamus. So the major hormone that is going to regulate the reproductive function from hypothalamus is gonadotropin releasing hormone. As the name indicates, the gonadotropin releasing hormone GnRH is going to act on the gonadotropes in the anterior pituitary, thereby going to release the gonadotropins, that is follicular stimulating hormone and luteinizing hormone. Experimentally, it was evident that GnRH pulses coincides very closely with luteinizing hormone pulses than the follicular stimulating hormone pulses. So this hormone is otherwise or synonymously called as luteinizing hormone releasing hormone. So now where does this GnRH comes from? It is a decapeptide with 10 amino acids, and the GnRH secreting neurons are present in the arcuate nuclei of the basal hypothalamus and the preoptic area of the anterior hypothalamus. From here, the neurons project through the median eminence and terminate in the capillaries. This portal vein then flow along the pituitary stalk to reach the anterior pituitary. These GnRH secreting neurons, that is in the arcuate nuclei and the preoptic area, embryologically they originate from the olfactory area and then they migrate along the olfactory nerve to reach their present location, that is the hypothalamus. This migration of the GnRH secreting neurons is mediated by cell-to-cell adhesion molecule. If there is any genetic mutation in these cell adhesion proteins, then it will lead to a syndrome called Kallmann syndrome, which is clinically characterized by anosmia, GnRH deficiency, and hypogonadotrophic hypogonadism. Now, this GnRH, which is secreted from the GnRH neurons, is not secreted continuously. Rather, it is secreted in pulses. The pulsatility of this GnRH discharge is regulated very critically in a particular frequency and in an amplitude. And the frequency or the pulses are going to decide the type of gonadotropin, that is either FSH or LH, which is going to be released from the gonadotrophs in the pituitary. And the pulsatile release of GnRH is also necessary for the upregulation of the GnRH receptors in the pituitary. So physiological periodicity of this pulses is around 60 to 90 minutes. Both lower frequency pulses as well as higher frequency pulses can cause anovulation, because lower frequency pulses cannot produce the sufficient stimulation, whereas the higher frequency pulses can cause desensitization of receptors or down regulation of the receptors, thereby leading to anovulation. And the frequency or the rhythm with which these pulses are released from the GnRH neurons also decide the type of gonadotropin which are going to be released. Rapid pulses will favor LH secretion and slow pulses will favor FSH secretion. And the pulses also vary across the menstrual cycle. That is, from early follicular phase to late luteal phase, the frequency of these pulses vary. So where do these GnRH pulses or pulsatility originates from? It is from the arcuate nucleus. The arcuate nucleus is the pulse generator, which is responsible for this intrinsic property of GnRH neurons. And these GnRH pulses are also regulated by the gonadal steroids. Here, estrogen will increase the GnRH pulse frequency and progesterone will decrease the GnRH pulse frequency. So, as we have seen earlier, increased pulses or rapid pulses will lead to LH release, whereas slow pulses will lead to FSH release. So, what happens here is estradiol, which is secreted during the late follicular phase, will increase the frequency of this GnRH pulses. And so, what is happening is LH secretion is increased. So, this increased sensitivity of GnRH pulses to estradiol is responsible for LH surge, which occurs before ovulation. Then after following ovulation, from the corpus luteum, progesterone is going to be secreted. This elevated progesterone will cause reduced pulsatility of the GnRH. So towards the late luteal phase, this progesterone will cause FSH secretion because of the slow pulsatile release from GnRH, and this FSH which will be utilized for follicular stimulation in the early follicular phase of the next menstrual cycle. Apart from this gonadal steroids, norepinephrine, dopamine, and endorphin also regulates the GnRH secretion. So this image shows that in the late follicular phase, more amount of estrogen will be there, and because of this estrogen, the sensitivity of the gonadotrophs to GnRH increases, thereby there occurs LH surge. When we see in the early follicular phase, LH surge is not seen, whereas in late follicular phase, due to increased production of estrogen, it enhances the sensitivity of gonadotrophs to GnRH, and this is the mechanism of LH surge. GnRH is also used therapeutically in the treatment of certain disorders like Kallmann syndrome, endometriosis, and uterine fibroid. This is based on the principle that continuous administration of GnRH will lead to down regulation of gonadotropin secretion by causing downregulation and desensitization of the receptors, whereas pulsatile release of GnRH will cause upregulation of the gonadotropes. That is why in Kalman syndrome, where we get hypogonadotrophic hypogonadism, we use pulsatile GnRH therapy. Whereas in endometriosis and uterine leiomyomas, we need to achieve an environment of hypoestrogenism. In such cases, we give continuous GnRH therapy to downregulate the gonadotropin secretion, thereby downregulating the ovarian estrogen secretion. So now we have seen from the hypothalamus, that is arcuate and preoptic area, GnRH pulses are secreted, and based on the pulsatility, whether it is slow frequency or high frequency, it will go and act on the anterior pituitary to release FSH and LH. Now we are here in the anterior pituitary. So where do these GnRH go and act? It acts on the gonadotropes, which are specialized cells in the anterior pituitary, which constitutes around 7 to 15% of the anterior pituitary cells. And these are the cells which are going to synthesis LH and FSH. This GnRH will go and act on the GnRH receptor, which is present in the gonadotrope. So this is the gonadotrope cell in the anterior pituitary. This GnRH receptors are G protein coupled receptors with the GQ subunit. Once the GnRH is going to attach with this G protein coupled receptor, it will lead to activation of phospholipase C, thereby leading to the formation of inositol triphosphate and diacylglycerol as second messengers. So this diacylglycerol will stimulate the protein kinase C, and the protein kinase C will phosphorylate the targets for gene transcription required for synthesis of luteinizing hormone and follicular stimulating hormone. These two hormones are secreted and stored in the granules. Now, this inositol triphosphate is going to cause calcium release from the intracellular stores, and this calcium will again cause calcium mediated opening of calcium channels, and finally exocytosis of these granules occur and the secretion of FSH and LH occurs. So GnRH, they act on the G protein coupled receptors on the membrane of the gonadotrough, and by phospholipase C and diacylglycerol and IP3 as second messengers, it leads to synthesis of FSH, LH, which is released. Now, GnRH has acted upon the gonadotropes and FSH and LH are released. What are these FSH and LH? That is gonadotropins. These are heterodimers with two peptide subunits. The alpha subunits of FSH, LH, TSH and beta HCG are similar. As we have seen earlier, the rhythm or the frequency of GnRH is going to determine the type of the gonadotropin that is going to be released. As I have said, they are similar in alpha subunit and they differ only in the beta subunit. That too, LH and beta HCG are similar in their beta subunit except in the last few terminal amino acid sequence. So they both are analogous and act upon each other. So now FSH and LH are secreted. How they are going to be regulated? The FSH and LH which is secreted are going to be regulated by negative feedback mechanism from the ovarian hormones, that is estrogen, progesterone and inhibin, which is going to be secreted from ovary, which we will see later. So this slide shows the pattern of gonadotropin levels throughout the life of a female. So here, two things we should notice. Initially, in the intrauterine life, that is around the first trimester, there is increased pulsatility of GnRH and so the LH and FSH. Then later it comes to the baseline. Again, immediately after birth, in the early infancy or the postnatal period, again it rises. Thereafter, it comes to the baseline and remain as such until puberty, where again the pulsatile and cyclical secretion of this gonadotropin start. Here, two things we should note. The reason for this pulsatile secretion at puberty and the LH and FH, elevated FSH and LH after menopause. There are various hypothetical mechanisms for it. They say that the hypothalamic pituitary axis is not mature enough to cause pulsatile release of LH or FSH before puberty. Only when the hypothalamic pituitary axis is mature enough and the ovary is going to secrete steroids, negative feedback mechanism occurs and the pulsatility starts. One more thing is the sensitivity of the gonadotropes to the steroid also decreases with increase in age. For example, if you see this image, in fetus or in infancy and childhood, the gonadotropins are highly sensitive to the peripheral steroids. So here, even though minimal quantity of ovarian steroids are secreted, this will cause inhibition of FSH and LH. So we are not going to get any LH surge or FSH surge. And gradually, when the hypothalamo-pituitary axis is going to mature, the sensitivity decreases. That is, more and more amount of estrogen or progesterone is required to cause this negative feedback. So with the maturation of the hypothalamo-pituitary tract, these cyclical monthly surges occur. And finally, at around menopause, the ovaries cease to synthesize steroids, and so by negative feedback, FSH and LH are elevated. Hope I'm clear. In that first trimester in intrauterine life and in the early postnatal period, they are elevated. Then it remains in the baseline until the hypothalamo-pituitary axis is mature enough to secrete FSH and LH as monthly surges. GnRH is secreted from the hypothalamus. Then it acted upon the gonadotropes by a G protein coupled receptor coupled to GQ subunit, from which LH and FSH are released. Now we'll move on to the gonads, female gonad, that is ovary. Now we'll see where these LH and FSH are going to act upon and how ovarian steroidogenesis is going to occur. So the two main objectives of ovaries are generation of a fertilizable ovum, and this ova is going to secrete the ovarian steroids. These ovarian steroids are going to act upon endometrium and prepare the endometrium either in both the ways, in the presence or absence of fertilization. The endometrium should be ready to accept things. That is done by this steroidal hormone secreted from the ovary. So where this FSH and LH gonads, they act on the receptors, respective receptors, that is FSH and LH receptors. These are also G protein coupled receptors linked to GAS subunit. And here we should note that FSH receptors are expressed exclusively by the granulosa cells, whereas LH and HCG receptors, as I've said earlier, they both are homologous in structure. So LH or HCG receptors, they are expressed primarily by the theca interstitial cells of the follicles, in all theca interstitial cells, and granulosa cell of the large preovulatory follicle. So here, the early follicle before antral formation, they have only FSH receptor in the granulosa cells, whereas nearing ovulation in the pre-ovulatory follicle, both FSH and LH receptors are present in the granulosa cells, and in theca cells, LH receptors alone are present. And the FSH also increases the expression of the LH receptors. So now, what this FSH is going to do to the ovary and how it is going to help in oogenesis. Now the FSH that is synthesized by the anterior pituitary is going to act on granulosa cell and it is going to promote follicular maturation. Here again we should note that the very initial stage, very early stages of follicular development, that is from the primordial and primary follicle, they are regulated only by the intra-ovarian mechanisms. And the later stages of follicular development from secondary oocyte also, it is pituitary dependent and FSH dependent. Initial stages can occur without the presence of FSH, but later, without the action of FSH, the ovarian follicle cannot develop into a secondary oocyte and it can go for atresia. And so, FSH is required to promote follicular maturation. And in addition to this, FSH is also responsible for the activity of the enzyme called aromatase. This enzyme aromatase is required for estrogen synthesis, which we will be seeing in my later slides, and FSH is required for it. In addition to that, FSH also increases the expression of the LH receptor on the granulosa cells. And FSH along with LH is required for complete oogenesis and for ovulation to occur. So what happens now if there is FSH receptor mutation? The patient will be presenting with amenorrhea, infertility, and poorly developed secondary sexual character with high levels of FSH and LH because the receptor is mutated. And clinically, the clinical features are similar to that of gonadal dysgenesis as occurs in Turner syndrome. But here, the major differentiating feature is that in FSH receptor mutation, the very early follicle, that is primordial or primary oocyte stage, follicles can be present. Follicles in the very early stage of development can be present, and because only after that FSH comes into play. Whereas in gonadal dysgenesis, there is complete absence of ovarian follicle. Now, what does this luteinizing hormone do to the ovary? There are two essential functions of it. One is to cause follicular rupture, that is ovulation, and the other one is to maintain the viability of the corpus luteum. Other than this, LH also plays a very important role in follicular function. That is, if they act on the theca cells to produce androgen, only this androgen, when it is carried on to the granulosa cell, can be converted to estrogen, and LH also plays a very important role in growth of follicles to pre-ovulatory stage. So now what happens when there is LH receptor mutation? Again, the person presents with amenorrhea but normally develops secondary sexual character, and here in ovary follicles are present but no pre-ovulatory or mature follicles or corpus lutea is not present in the ovary. And the next applied thing is luteal deficiency. As I have said, the two major functions of this LH is to cause ovulation, and the other one is to maintain the viability of corpus luteum. So when there is a deficiency of this, the corpus luteum will undergo regression, and so this corpus luteum, which is responsible for the supply of progesterone during the early pregnancy, is lost, and this leads to recurrent miscarriages. And this is one of the commonest cause of infertility. This is treated by administration of either progesterone or HCG. Now we have seen what is FSH and LH, what is the action of FSH and LH on the ovary. Now we are going to concentrate on how ovary is going to synthesize this ovarian steroids. The pre-ovulatory follicle will secrete estradiol during the first half of the menstrual cycle, and after ovulation, corpus luteum will secrete both estradiol and progesterone. Ovaries also secrete other hormone, but the biological active ovarian steroids are estradiol and progesterone. So there are three major categories of ovarian steroids: C18, C21 and 19 steroids. C18 steroids are the naturally occurring estrogens. On the further synthesis of these steroids, we need aromatase, which is the key enzyme. So as we have seen earlier, FSH is going to act on the granulosa cell and cause secretion of estrogen, and the action of FSH is through this aromatase enzyme. And C21 steroids that are secreted from ovary are pregnenolone, progesterone, and 17-hydroxyprogesterone. As we all know, pregnenolone is the precursor of all steroid hormones, and progesterone is the principal hormone of corpus luteum. This progesterone is responsible for all the progestational effects, that is secretory activity of endometrium and preparation of the endometrium for implantation of the fertilized ovum, and maintenance of pregnancy by synthesis of progesterone by corpus luteum, and so on. And the C19 steroids are dehydroepiandrosterone, androstenedione, and testosterone. And among this, the major is androstenedione. This androstenedione will again be converted into estrogen or testosterone. Here we see the two-cell theory of ovarian steroidogenesis. And this is Theca cell and this is granulosa cell. As we have seen earlier, Theca cells, they have LH receptor. Granulosa cell has FSH receptor in follicles of all stages, whereas in the pre-ovulatory follicle or the mature ovarian follicle, both LSH and FSH receptors are present. Now, what are these receptors? Both FSH and LH receptors are G protein coupled receptor that acts through GS subunit, thereby causing activation of adenyl cyclase. So, any steroid hormone, we need cholesterol for the synthesis. Where do this cholesterol comes from? This cholesterol can be from the cholesterol in the plasma, or cholesterol can be synthesized de novo in the cell or from the cholesterol stores. Here, for ovarian steroidal synthesis, this LDL cholesterol is from the plasma. So, the rate limiting step here is the transfer of this LDL cholesterol into the mitochondria, and this is regulated by a protein called star protein, that is sterol acute regulatory protein, and then cholesterol is converted into pregnenolone by P450 side chain cleaving enzyme. These two are the rate limiting steps, and in the Theca cells, LH by activation of adenyl cyclase mediates the synthesis of androstenedione and testosterone at these two levels, that is at the level of star protein and at the level of this enzyme. And androstenedione and testosterone are secreted by Theca cells of the ovary. Now, and also progesterone. Now, this androstenedione enters the blood and then also to the granulosa cell. It is in the granulosa cell where this androstenedione is converted into estradiol, which is a biologically active ovarian steroid. And this is done by the enzyme aromatase. And here comes the action of FSH. FSH acts on the G protein coupled receptor in the granulosa cell, which is mediated, and then adenyl cyclase mediated activation of protein kinase acts for the activation of this aromatase. So FSH acts through this aromatase enzyme in converting the androstenedione to estradiol. And this occurs in the follicular phase. In the luteal phase, what happens is, we have seen in the luteal phase, LH in the granulosa lutein cells, LH receptors are also present. LH also comes and acts over here. Again, similar to the action of LH in the Theca cells, here also LH acts by activating the enzyme that helps in the convert of cholesterol to pregnenolone, and finally progesterone is formed by the follicle, that is corpus luteum, after ovulation. Here two things we have to take care is that the Theca cells, they do not have aromatase, so estradiol is not secreted here. Whereas in the granulosa cell, only till progesterone secretion is possible, following which androstenedione cannot occur because of the absence of the enzyme 17-alpha hydroxylase and 17-20 desmolase. These enzymes are present only in the Theca cells. So this is called Theca granulosa cells crosstalk. They interact with each other in the secretion of the ovarian steroids. In addition to this ovarian steroids, ovaries also secrete some peptide hormones. They are activin and inhibin. Activin is secreted by the granulosa cell during the early follicular phase. So this activin will go and stimulate FSH and LH in the early follicular phase, whereas inhibin is secreted by the granulosa cells in the late follicular phase, and this inhibin will inhibit the FSH and LH secretion. So, to sum up the hormonal changes occurring during ovarian cycle, we'll start with mid-luteal phase. In the mid-luteal phase, we have corpus luteum, which is secreting estrogen, progesterone, and inhibin. This by negative feedback will inhibit the FSH. In the late luteal phase, in the mid-luteal phase, later at the end of the luteal phase, when the corpus luteum is going to regress, this estrogen and progesterone will not be present, and so this negative inhibition of FSH is abolished. Since this is abolished just before the onset of menstruation, FSH is available during the early follicular phase of next cycle to ensure proper follicular development and steroidogenesis. And again, in the follicular phase of the next cycle, the same cycle continues. FSH leads to secretion of actin, and which in turn leads to estrogen secretion, LH surge, and finally ovulation and corpus luteum formation occurs. After the formation of corpus luteum, the cycle will again continue, that estrogen, progesterone, and inhibin will be secreted, which will again inhibit this FSH. So this is the follicular phase and this is the luteal phase. In the follicular phase, FSH is there and the growing ovarian follicle secretes estradiol. As we have seen earlier, due to increased estradiol secretion, the sensitivity of the GnRH neurons, the gonadotropes to GnRH will increase, and estradiol will increase the pulse of LH and FSH, thereby LH surge and ovulation is occurring. Following ovulation, there will be increased secretion of estrogen and progesterone. This progesterone, which is going to be very much elevated in the luteal phase, is going to cause reduced pulsatility from the GnRH neuron, and also by negative feedback inhibition, FSH and LH levels are low over the luteal phase of the menstrual cycle. So now the ovaries have secreted the steroids. Now it is going to act on the endometrium. Endometrium is the mucosal lining of the uterine cavity. During pregnancy, this endometrium can be modified and it is called decidua. This endometrium, I think my screen is not visible now. Let me share again.
It's not visible.
One second, share it. My screen is visible, right?
Yes.
Not yet.
Yes, visible.
Sorry, yes. So now we are here in endometrium. The ovarian steroids that are secreted are going to act on this endometrium. The endometrium, when it is ready for implantation or during pregnancy, it is called decidua. And we also have spiral arteries over the spiral arteries in the endometrium, which are of clinical importance both in menstruation and also in the implantation of the blastocyst. And the estrogen and progesterone, which is secreted by the ovary, is going to act on this endometrium. And what is the effect of estrogen and progesterone on endometrium? Estrogen will cause rapid proliferation of the endometrium. I think again my slide is not visible. Sorry, I'll share it again now.
Visible right now.
Yes. Sorry for the interruption. And under the effect of progesterone, endometrium will undergo differentiation, and progesterone will also reduce the number of estrogen receptors in the endometrium. And Based on the effect of these hormones, the endometrial cycle can be divided broadly into 5 main stages. That is, immediately after menstruation, re-epithelialization, then the proliferative phase, secretory phase, then premenstrual ischemia, and finally the menstruation. There is something called as the receptive phase of the endometrium. That is the window period during which the endometrium is ready to accept the fertilized ova. As we all know, fertilization takes place in the ampullary part of the oviduct, and first 2 days after fertilization, the fertilized ova receives its nourishments from the tubal fluid only. Later, it reaches the uterine cavity where it gets its nourishments from the progesterone secreted from corpus luteum that is maintained by HCG produced by the trophoblast. So there is a window period from the period of transfer to the period of implantation. That is the period from during which the embryo is going to reach the endometrium and when it is going to get implanted properly. This temporal window period is around 4 days, and this is of importance in embryo transfer. And clinically, we are doing endometrial biopsies to histologically determine the phase in which the endometrium is. This is called histological dating. Normally, histological dating and chronological dating should be within 2 days. If it is more than 2 days, then the endometrium is said to be out of phase, and this can lead to implantation failure and infertility. But one important disadvantage of this endometrial biopsy is that there can be inter-observer variation. And clinically, this is very important in embryo IVF and embryo transfer, where we give the synthetic hormones estrogen and progesterone, and we do embryo transfer in IVF. Here, one thing we have to notice that the fertility potential of the women is determined by the quality of the oocyte, which regresses or declines with increase in age, whereas the endometrial function is not so. Endometrium is biologically potential even at advanced ages. So we are done with the hormones in female reproductive system. Since we are running short of time, I'll just skip the hormones in pregnancy. I think all of us are well aware of it. So these 4 are the major hormones in pregnancy. And estrogen, progesterone, we have discussed in female reproductive system only. Now we'll move on to the hormones in male reproductive system. So again, the hypothalamo-pituitary testicular axis has 2 major functions. One is the production of male gametes, that is to aid in spermatogenesis, and the other is to aid in androgen biosynthesis or testosterone biosynthesis by the Leydig cells in testes. Again, male reproductive system, we'll start with hypothalamus. So everything is homologous with the female reproductive system. We have seen everything well in advance. Here also the GnRH is secreted from the arcuate nucleus and the preoptic area. Slow frequency favors FSH, and rapid pulses of GnRH stimulates the LH secretion, which will go and act upon the gonadotropins to release FSH and LH. Here too, the GnRH is secreted in a pulsatile fashion, that is around 8 to 14 pulses in 24 hours. That is each pulse of around 1.5 hours. And the continuous administration of GnRH will again lead to downregulation of the gonadotropes, thereby leading to reduced synthesis of the gonadal steroids. And so this is again GnRH therapy is used in the treatment of testosterone dependent prostate cancers. This GnRH, just like in female reproductive axis, it acts on the G protein coupled receptor, which is coupled to GAQ subunit, activation of phospholipase C, thereby leading to the release of FSH and LH from the anterior pituitary. Now this LSH and FH are going to act on Leydig cells and Sertoli cells. Here LH will act on Leydig cells and FSH will act on Sertoli cells. So the luteinizing hormone receptor is located on Leydig cells, just like ovary, what happened in theca cells. Here also, these receptors are G protein coupled receptor, which are linked to GS subunit, which will in turn lead to protein kinase activation and synthesis of testosterone. This testosterone is necessary for regulation of normal spermatogenesis, and so this LH is therapeutically used to initiate spermatogenesis in azoospermia. Now, what is the action of follicular stimulating hormone in testis? I have mentioned earlier, it acts on the Sertoli cells, the same G protein receptors coupled to GS subunit, and it also induces maturation of the Leydig cells. Just like in female reproductive axis, here also the gonadotropin secretion varies with developmental age. Initially, in the first trimester, it increases, then attains a plateau, then immediately after the birth, in the initial neonatal period, again it increases, and thereafter it comes to the baseline until the hypothalamo-pituitary axis become mature enough to release the GnRH and the gonadotropins. Now, the anterior pituitary hormones are going to act on LH and FSH. So, there we have seen in theca cells and granulosa cells. Here also, Leydig cells act, the LH receptors are present on the Leydig cells and FSH receptors are present on the Sertoli cells. This LH receptor will causes activation of adenyl cyclase, protein kinase A, thereby leading to new protein synthesis that is required for the enzymes that are involved in the pathway of synthesis of testosterone from cholesterol. Now, Leydig cell has secreted testosterone with the help of luteinizing hormone. Now, this testosterone is going to reach the Sertoli cell. Again, for this Sertoli cells, testosterone can be utilized for regulation of normal spermatogenesis, and it can also be converted into estradiol by the enzyme aromatase. So, this enzyme aromatase is mediated by this FSH. This is regulated by FSH. The FSH, which is going to act on Sertoli cell, will cause activation of protein kinase, and it leads to synthesis of aromatase, which will convert this testosterone to estradiol, androgen binding protein to which the testosterone will bind, and it will maintain increased concentration of testosterone, so for the spermatogenesis to occur, and it will also synthesize inhibin and other growth factors which will enhance the action of Leydig cells. So for spermatogenesis to occur, we need two cells, that is Leydig cells and Sertoli cells, two gonadotrophins, that is FSH and LH, and one hormone, that is testosterone. Now the testis, with the help of this LH and FSH, it secretes testosterone, dihydrotestosterone, and androstenedione, among which testosterone is the most abundant. This is the pathway of secretion of testosterone. In the peripheral tissue or in the target tissue, this testosterone is converted into dihydrotestosterone by 5-alpha reductase. So that is how this testosterone acts. It goes and acts on the testosterone receptor, which is a nuclear receptor, or the dihydrotestosterone receptor, and it will help in spermatogenesis, sexual differentiation, sexual maturation, and also control the gonadotropin secretion. Now we come to the end of this talk, and to summarize, in female reproductive axis, GnRH is released from the hypothalamus, which is going to act on the GnRH receptors, which are G protein coupled receptors in the anterior pituitary, and from here the FSH and LH are separated. Now LH will act on the receptors in the theca cells, FSH will act on the receptor in the granulosa cell. In addition to this, LH also acts on the receptor in the mature granulosa cell in the luteal phase, and from the theca cells, androgens are secreted, which will again reach the granulosa cells to be converted into estrogen. And estrogen and progesterone have negative feedback on hypothalamus and anterior pituitary. And we are also aware that this estrogen immediately just before ovulation has a positive feedback on hypothalamus, thereby causing LH surge. From the granulosa cell, inhibins and activins are secreted. Inhibin will inhibit FSH secretion and activin will stimulate FSH secretion. Similarly, in the male reproductive tract, GnRH leads to release of LH and FSH. LH acts on Leydig cell for androgen secretion and FSH acts on Sertoli cells to increase the growth factor to enhance the secretion of this aromatase enzyme, which is needed for peripheral aromatization of androgen to estrogen, synthesis of androgen binding protein, and also aids in spermatogenesis. Thank you.
Thank you, ma'am, for your informative talk. I request all the delegates to kindly put your questions in the chat box, which will be taken at the end of our session. I once again request Ms. Hemalata ma'am to introduce our next speaker, Dr. Gopinath sir, Associate Professor, Department of Physiology. Over to you, ma'am.
Dr. Gopinath sir has did his UG from Trichy Government Medical College and post-graduation from the JIPMER, Puducherry. Sir is active resource person in medical education unit, and also he completed his postgraduate degree in postgraduate course in the diabetology. Sir has a research working experience in heart rate variability, pulmonary function test, nerve conduction studies. He has various publications in national and international journals, and is authored in 2 chapters in Handbook of Practical Physiology. Over to you, sir. Welcome to you.
Thank you, ma'am. Very good afternoon to one and all present here. My talk will be the role of stress on reproductive functions. So as we all know, this infertility as a global health burden, which is prevalent in our country. Getting a child is being a social stigma in our society. So on this note, many investigations are being carried out to investigate both male and female. And at the end of all the investigations are normal. There exists an important factor which is called as stress. So alleviate stress or remove stress and then come to us. This is the usual advice which is given by the reproductive physicians. So here, this talk is going to be much essential on the perspective of stress on reproductive function. The schema of my presentation will be on what is stress, recipe of stress, and different stressors which is available, and biology of stress, what is acute stress and chronic stress, and different mechanism how stress is acting on the bodily functions, and stress on endocrine hormones, and how stress can be recognized and it can be managed efficiently in a short aspect. Well, what is stress? Stress can be explained in many words, many formalities, many factors, but there was a Canadian endocrinologist named Hans Selye. He was one of the father of stress research, and he defined it as stress is defined as a state of disharmony, which is also called as cacostasis or allostasis, and it can be counteracted by an intricate repertoire of physiological and behavioral responses which aim to maintain or re-establish the threatened homeostasis, which he called it as adaptive stress response. He proposed that stress was a non-specific strain on the body, which is caused by many irregularities in the normal body functions. So this stress resulted in release of all the stress hormones, and he called this as general adaptation syndrome or gas model. So our body's short-term and long-term reaction to stress. So here, after pioneering in this field of stress research, Hans Selye has documented that stress to be a non-specific physiological phenomena. But many other researchers, they counteracted and they didn't agree to be as a non-specific strain, because this non-specific phenomenon, if it has to be a non-specific physiological stress, then all the human beings or all of us should react in the same way to a particular stress. But this doesn't happen. So then many other researchers, they told that there was many other common elements which would have provoked the stress response in our body. So here, a famous physician, John Mason, he conducted an experiment by having a two group of monkeys. So in the group one monkey, it was being put in a cage without any food. Okay, so it was the monkey was there in a state of hunger. There was another group of monkey where the monkey was seeing people eating. So both were in a cage, both were in the same state of physical state of hunger. It was mentioned as stress, but they measured the stress hormone level, wherein they found that the group 2 monkeys, which been put in cage, the same state of hunger was there, but they developed more stress level hormones, because this other group of monkey, they didn't see people eating, so they were put in a hunger state in a cage. But the other group of monkeys, they were seeing people eating, and he was there in the anticipation of getting that food. And this concept has also been told by other researchers, like they took a two group of parachute jumpers. So in that first group was people who are there in first time handling that parachute jumping. So they were the trainees. So the other group had all the instructors in that group. So when they been analyzed for the stress hormone level on that particular day of parachute jumping, what they observed is the new people who have been about to jump on that first day, so their hormone levels was elevated, stress hormone levels was elevated only on that particular day, that is on the day morning. Whereas the other group who are called as instructors, their stress level hormones was increased just 24 hours before itself. So this was considered as an essential factor, that anticipating the event which is going to come in after some time, which increase stress hormone levels in enormous quantity. So here, this theory, which is called as gas model, general adaptation syndrome, was developed by Selye. He suggested that a person's response to a stressor, it consists of three stages. That is alarm and mobilization, and second stage is resistance stage, and third stage is exhaustion stage. So he found that in first stage, that is stage 1, alarm and mobilization, the flight and fight response was there immediate when any particular stressor. So immediately after exposing to that particular stressor, the person is reacting in a way with a flight and fight response. So there also there was elevation of stress hormones. So but this stage should be in a shorter period of time. And then stage 2, which is called a stage of resistance. If the stress is continuing for a longer time, the body is getting adapted to the stressors, and it is trying to manage it, which we call it as habituation. But this stage of resistance is little harmful to the people, wherein this adaptation is going to increase the stress hormone level for a longer period of time. And then if it is continuing for a longer period of time, it is going to definitely affect the different bodily functions. And stage 3 is, which is called a stage of exhaustion, where the stress continues to exist for a longer time, and this immune system is going to be ineffective. He's not able to fight against that kind of stress which he has been exposed to. So that stage 3 is called a stage of exhaustion, where the immune system is getting failed and is prone to have all infections and other heart diseases. So this is a person is getting exposed to a stressor, and he's meeting it, and he's trying to resist the stressor, and he's trying to cope with the stressor, and trying to resist the stressor also. But if he's failing in that, it will have all the negative consequences of stress, such as illness, when the coping is inadequate. Okay, the next is, what is the source and recipe of stress? The word recipe itself, which looked very attractive. The stressor is a chemical or a biological agent or any environmental condition or an external stimulus or an event. All these conditions can be defined as a stressor. So the stressor can be both physiological and psychological also. Some of the stressors which we face, like from a school life for students and work, family relationships and legal issues, financial issues, and health and illness of any of our family members, and environment itself where we are working and where we are living, which will be a stressor event, and living situation, what kind of economic status we are there in, that also will definitely have a stress response. And what are the negative effects of stress? So it has physical responses like weight gain, loss, unexpected hair loss, an increase in heart rate, which is called as palpitation, high blood pressure, which is more prone to have cardiac diseases, and emotional effects like mood swings, anxiety, and can lead to depression also, and can also lead to unhealthy coping strategies like addiction to alcohol and drugs. So here, this wheel explains the entire sources of stress, which can be variedly coming from different sources like social, career, spiritual life, and health aspects, and financial aspects, intellectually, where we work and pursue our things, and family stress. So these are the different stress we experience in our life. A person can have all these black letters which is mentioned above his head: no sleep, fear, worry about health, there is no time for me to work, or I'm very tired with my all kind of works, and my job is not satisfiable, I'm not getting promotion, I'm not getting proper salary, on all these debt, loans, what we perceive. So almost all these black letters will be a stressors for the particular person. So who get the stress? So any guesses who gets the stress? Only adult people, or who perceive all these kind of family life and work people? No. So many researchers have shown that even children and also old people above 65 years also, they are prone to have stress effects, and they measure their stress hormone levels, and we have a very good number of studies which tells that even children and very old age people, geriatric people also suffer with kind of stress response. So stress as an equal opportunity factor. So all age group, material of age, gender, their level of income, their level of socioeconomic status, their level of education, every one of us will be experienced to a stress factor. And very beautiful picture which attracted me. It's not stress that kills us, it's our reaction to it. Many a times the stressors are not only the important one, which is creating the increase in stress hormone levels, but our reaction to it, how we react to it. Some of the person, one of my friend will react in a lesser way, but I will react in a seriously in a different way. So this response from our system to a stressor, it matters a lot. So stressors, which causes the release of stress hormones, it can be physiological stressors or it can be a psychological stressors. And the stressors can also be divided into absolute stressors and relative stressors. The stressors that everyone would have exposed, which is really stressful, like earthquake, tsunami, and demonetization, which we experienced, and COVID pandemic. So they are categorized under absolute stressors, whereas relative stressors are, they are only a particular person is exposed and he will interpret as it is stressful. So it is very subjective. It can be work pressure, or traffic, which I'm going to attend a very important meeting, or exam stress, or family stress. They all come under relative stressors. Right. Next, what are the ingredients of stress, or what is the recipe of stress? So this was categorized with an abbreviation which is called as NUTS. N is for novelty, and U is for unpredictability, and T is threat to the ego, and fourth, S is sense of control. So this NUTS, NUTS, which is the recipe of stress, which is novelty is something new you have not experienced before. Like I am pursuing some kind of new software program, or I'm going to pursue some new learning process, like I'm going to drive a car or learn a car, or going to learn a new instrument. or all these kind of new ventures what I'm going to do, which comes under novelty. So something which I'm not exposed to that or experienced before. So that will create a stress response in me. Next is unpredictability. Unpredictability is something I have no way of knowing it would occur. I have I'm watching a match or cricket match or some other very important event. I will not know what is going to happen next. So that unpredictability, in your work profession also, you have a boss who's very moody, who often yells at you. You don't know at what point of time he's going to be very harsh with you. So this unpredictable nature, daily you are working, and this also can increase the stress response. And third one is threat to the ego. So your competency as a person is called into question. That is, if you are being a senior person, one of your junior person, if he's always doubting your competency, what is this, what is that, why you are doing like that. So if he's always pondering on you, so that is also going to be a stressor every day in your working experience. And fourth one is sense of control. You feel that you have little or not control or do not have any control over the situation. So any of the family members is sick or any illness or these kind of COVID pandemic, all these things can lead to this fourth one, which is called a sense of control. You don't have any control over the situation. So this novelty, unpredictability, threat to the ego, and sense of control, which was very oblivious to know about the recipe of stress. And the stress is it has been weighed in a additive way. So more ingredients, more stress. So as I mentioned in nuts, if n is more, I'll get more stress, and n is added with u also, then unpredictability, that also will add to my stress or response. Then it is added to the t, that is threat to the ego, that also will add to my stress response. So stress is an additive way. So more ingredients will lead to more stress. And several factors which determine the stress response system. Like every individual will react to a particular stressor in a different way, depending on their way of upbringing. So I'll be able to handle stress in a better way, but my friend will not be able to do. So these kind of factors and level of education. An educated person or another good way who has experienced many stressors in his life, he will handle it in a better way. So several factors which determine the stress response system. And the third one is, I mentioned with that parachute jumping, expecting the worst. So anticipation. When I have a presentation today, or I'm going to have a very important meeting today, I anticipate that well before that this is going to happen. My stress hormones levels are increased in an enormous way. So expecting the worst or anticipating the event will also lead to a stress response. So can stress be recognized? If I recognize it, it's called as perceived stress. Can I recognize, or I will not be able to? So this is very important. When was the last time I was stressed? So to know about that, to think about that, you need a little more consciousness, right? Then second one is, how do I know that? How do I know that whether I perceive novelty kind of stress, or I perceive unpredictable stress or threat to the ego? And third one is, can I describe what I felt? So I am exposed to a stressor. Can I explain what kind of stressor I'm exposed to? So can I describe what I felt? So all these three questions are very important to know about a perceiving stressor type. And this is about acute and chronic stress. I was talking about acute stress. So all this stress which has been coming in the first and second stage, that is stress resulting from specific events or situation, which is going to increase enormously your stress hormones, will come under acute stress. So on the spot release of stress hormone, which helps in managing the stress by activating many bodily systems. Whereas a chronic stress, that is very dangerous. So chronic stress over a period of time, repeated exposure to situation, which causes wear and tear of your mind and body. So which is called as overuse of your stress level hormones. So this graphical representation, which told about the physiological response. So the x-axis, which is plotted against time, and y-axis, which is plotted against physiological response. So here, as the time goes, when the stressor is there, my stress level hormones are increasing, and gradually when the stressor is removed, the stress level hormones will come down. So it is for a shorter period of time, which will hold for acute stress. Whereas the next thing is, that is repeated hits. When I'm exposed to that stressor for a longer period, so normal response repeated over a time. So there is an increase in level of stress hormones. Again, it is decreasing. Again, there is an increase. Again, there is a decrease in stress level hormones. This is called repeated hits. What is happening after some time? After some time, the same type of stressor is available. My stress hormone will go up and down, but it will habituate. So habituation is a normal physiological response wherein my stress hormone levels will, the ups and downs of stress hormone levels will gradually decrease. So this is normal adaptation. But if my stress hormone level is not getting adapted, it's called as lack of adaptation, or this is the later response, which is called as prolonged response or no recovery at all. So the stressor is there, my stress level hormones are elevated for a longer duration of time, and it is persistently increased. Okay, and this another one is inadequate response, which we call it as post-traumatic stress disorder. After which is called as PTSD, all my stress hormones levels are burnt out. Burnt out means there is no elevation of stress hormones in this kind of individual. So the response is inadequate in this type of physiological response. Right. Next question is all stress are bad, or some of the stress are good also? Moderate levels of stress may actually improve your performance and efficiency, and too little stress also will result in boredom. So we need some interesting life. So too much of stress may also cause an unproductive anxiety level and release in stress hormones. So they call it as good stress. Good stress is eustress. So getting into a college, I'm into a new environment, I'm going to meet my friends or new friends, a new place which is far away from my home, even though it will be making you down, or sometimes it increases your stress hormones in a good way. So getting into college, getting married in adolescent age, or winning a prize money after a good paper presentation or something like that, and passing the examination with top ranks. So all these things which increases your stress hormones, which they categorize as eustress or good stress. This is talking about the mechanism of stress, how the stress hormones are increased. So particularly we talk about catecholamines. Catecholamines are the hormones that are greatly affected during stress, and continued exposure to catecholamines creates many negative physiological and psychological impacts on an individual. So it reduces the effect of the neurotransmitters that are supposed to regulate your mood and emotions. So mood and emotions is very important for a healthier reproductive life. So it also might lead to inflammation of the organs in extreme conditions and failure of all your adaptive systems. So this is going to be a major reason. So first, the perception of the threat is called as stressor. Who is going to perceive your threat? So this is done by your hypothalamus. So hypothalamus, he perceives your stress and activation of autonomic nervous system. So activation of autonomic system, particularly there will be sympathetic dominance and parasympathetic separation. So parasympathetic dominance will help you in a very nice or good release of all the other hormones and other reproductive lives also. So increase in sympathetic activity will result in increase in cardiac output, increase in heart rate, and particularly in reproductive life, it is going to decrease the performance and premature ejaculation and all other problems and disorders of reproductive life. It comes because of the sympathetic dominance. And stimulation of HPA axis, that is hypothalamus pituitary adrenal axis, by releasing corticotrophin releasing hormone. So CRH is the hormone which is going to get released from hypothalamus on pituitary, and pituitary is going to secrete more ACTH secretion, adrenocorticotrophic hormone. So ACTH secretion will be there, and this secretion of ADH. ADH is arginine vasopressin, that is antidiuretic hormone, which is a postpituitary hormone. So the primary effects of ACTH secretion will be by HPA axis, and this ADH, that is arginine vasopressin, also will have an intermediate effect by stimulating the hypothalamus pituitary adrenal axis by releasing corticotrophin releasing hormone. So all the sympathetic dominance also. So primarily there will be release of more ACTH hormone, and by activating this ANS, autonomic nervous system, by increasing the sympathetic dominance, there will be more release of catecholamines. So all these three are interrelated, and all they help in or they aid in hypothalamic pituitary adrenal axis disruption. So this will result in many changes. So cardiovascular changes like increase in heart rate, increase in vasoconstriction to the non-working muscles. Usually during this anxiety levels, the primary organs like heart and kidney will have a vasodilatory effect. So blood supply will be going to that particular working muscles, whereas vasoconstriction will happen in the other non-working muscles. and increase the force of contraction, which is going to decrease your cardiac performance, and gradually you'll be more sympathetic individual, and there is disruption of sympathetic balance also. And this is a flowchart to show how the hormones released from hypothalamus. From hypothalamus, it is CRH. It is going to stimulate anterior pituitary, and anterior pituitary is going to secrete ACTH, and it is going to act on adrenal glands, which is there at the top of the kidney, and ACTH is going to stimulate adrenal glands to secrete more amount of glucocorticoids, cortisol. And this cortisol is going to have good effects when it is secreted in a shorter amount, as I mentioned, in acute stress. When it is going to be there for a longer period, as in chronic stress, it is going to have a deleterious effects like increased blood sugar, heightened loss of memory and attention, increase in blood pressure. It can affect ovulation also, and it can decrease the serotonin. So that is going to decrease your sleep duration, sleep quality also, and definitely it is going to suppress your immune system, wherein you'll develop all the heart disorders and other preponderance of infections. So this higher stress, cortisol secretion will be more, and this is going to lower the GnRH. GnRH is gonadotropin releasing hormone. It is going to lower the GnRH secretion, and finally it is going to decrease FSH and LH secretion, and this ovulation is getting disrupted as a result of this. As estrogen and progesterone is also decreased, testosterone production is also getting disrupted, and all menstrual disturbances and male disorders also end up. And there are I have observed some beautiful studies which mentioned about rise in has an effect on prolactin. So stress also has an effect on prolactin, which is leading to irregular menstrual cycles, and sometimes even which can lead to polycystic ovarian syndrome, which is been published in American Journal of Human Biology. And role of thyroid hormone. So here, the thyroid hormone levels also are affected by stress. Their levels get decreased with an increase in stress, thus causing hypothyroidism, and sometimes it can increase the levels for a shorter period, which can lead to hyperthyroidism, which will result in all reproductive disorders. And the third one, which has an impact on insulin also. Insulin is also seen to decrease due to prolonged stress. Which develop insulin resistance, and thereby it can affect the reproductive functions also. And next comes the serotonin. I told about the level of sleep. Level of serotonin and melatonin is very important. Though serotonin and melatonin are not considered as a stress hormones, yet they are associated with mood. So a decrease in the level of serotonin and levels of these, they can lead to depression, and chronic depression can interfere with reproductive system both in men and women. So since sex life depends on fitness of both body and mind, this chronic stress can result in decrease in libido, may even cause erectile dysfunction or impotency in men. In case of chronic stress, as I mentioned before, testosterone levels will drop down like anything, and it may interfere with the spermatogenesis, sperm quality, count, and motility also. And in women, it affects the menstrual cycle. So there is disruption of the entire menstrual cycle itself. So sleep deprivation, if several cases has been analyzed for these kind of cardiometabolic and reproductive dysfunctions, and increased ACTH and corticosterone secretion, which has a greater effect by paradoxical sleep deprivation. An effect of sleep deprivation on the male reproductive system in rats. There are many studies available. So these are all the studies which I wanted to quote. And this flowchart beautifully explains about the effect of sleep deprivation on infertility. So sleep deprivation, which can result in increase in stressful stimuli, which can activate HPA axis, that is hypothalamus, pituitary adrenal axis, which can increase the corticosteroids, decrease the testosterone level, and thereby in females also, it inhibits the hypothalamus pituitary gonadal axis. It decreases the luteinizing hormone, and thereby it increases the apoptosis of Leydig cells, which is one of the causes for infertility, and it inhibits the serotonin production, thereby it inhibits the testosterone production also. And when I was searching for this, and this was a quite interesting shift work stress. Those people who work in many MNC companies, they are under stress. Definitely, they are under shift work stress, which produces sleep deprivation, circadian desynchrony, melatonin suppression. So all these things, they produce decrease in GnRH secretion. They produce diabetes by causing insulin resistance, and they increase the oxidative stress. So all this pathophysiology leads to increase in early pregnancy loss, miscarriages. Very increased number of miscarriages are there in adolescent age group, those are working in shift work, and increase the FSH quality, and they increase the prolactin levels also. So finally, they lead to anovulation and amenorrhea by having an effect on estrogen and progesterone and luteinizing hormone also. So all these effects, they lead to infertility. So how do we cope with stress? There are many solutions, or there is no solutions at all. Eliminate stress from our life, which is impossible or possible. Definitely it is impossible. Learn to live with stress is definitely possible. So there are principles and laws how to manage cope or cope up with stress. The principles are there are no easy solutions and there are no universal solutions. And laws, the situation is only stressful if you interpret it as being stressful. It comprises the components called as nuts. Okay, so how you deal with the stress. So this is why stress is an individualistic or subjective personal phenomenon, which is novel to you, may not be novel to others. So kindly accept the fall from others also. So everyone deals with stress in a different way. That is why there are no universal stress management techniques. But even then, certain techniques, coping strategies are available. They categorized under problem-focused strategy and emotion-focused strategy. Like you please analyze the situation, pay attention, and avoid taking on more responsibility than you can manage. Work harder, stay up all through the night and study for an exam or prepare for any kind of endeavors. Apply what you have already learned to your daily life. You lose your job for the second time. This is an example, like you lose for the job second time. Already you have known what will be the impact on you because of that issue. So you know how to apply for the new job or search for another job. So take it in an easier way and talk to a person that has a greater impact on the situation. Talk directly to your boss or ask for any kind of extension of a project or which is due on the week or any other solutions for that particular problem. An emotion focused strategy, which is categorized as you accept new tasks instead of saying no. So we have a boss. We do not usually say no. So we always accept new endeavors every now and then that results in a decrease in your performance. So that can be better avoided. And imagine and magic thinking. You dream about a better financial situation. You think positively and avoid everything that is related to your depression kind of things. And you seek for a social support. It can be a friend or a family member, and blame yourself for that particular stress and start accepting it. The key word is balance the stress which is there in your life. And these are all the few apps which I found which can be very useful for you to relieve or alleviate stress, like Calm, Om1 app. Which gives you many techniques to get relieved from your stress response. And this is a very beautiful link which gives you many mindful exercises which you can follow through, and sit alone for at least half an hour or 1 hour and think about the entire day-to-day activities, what has been performed since morning, and analyze it and try to get a better solution for it instead of worrying about it. And any questions, I'll be happy to answer.
Thank you, sir, for your eye-opening session. Now we can take up the questions in the chat box.
I don't think there are any questions in the chat box. Now that we do not have any questions, so I think we will just wind up with the forenoon session, and we'll meet again at 2 p.m. We have 3 very interesting lectures in the afternoon. Kindly stay back and join us for the afternoon session. Thank you. We will see you again at 2 p.m. Thank you.
Dr. Shashikala has completed her UG from Chengalpet Government Medical College and PG degree in obstetrics and gynecology from UCMS and GTB Hospital, New Delhi. Ma'am has also completed 3 years of senior residency from JIPMA, and she is currently the consultant in reproductive medicine in Srishti Assisted Fertility and Advanced Laparoscopic Center. We are happy to have you, ma'am. Over to you, ma'am. The screen is yours. Ma'am, we have made you the presenter, ma'am.
Okay,
can
thank
share
you.
your
Thank you so much.
Thank you.
Good
ma'am.
afternoon, everyone. I'm Dr. Sasikala, a reproductive medicine consultant from Srishti Assisted Fertility and Advanced Laparoscopy Center. Am I audible?
Yes, ma'am, you're audible, ma'am.
Okay, thank you. So, I thank the organizing team and Dr. Sebanti and Dr. Dash for giving me this opportunity. So, my topic for today is subfertility in females. So, going on to the overview, we'll be dealing with the definition, risk factors, causes, evaluation, management in brief, and conclusion. So, by definition, the female subfertility refers to failure to achieve a successful pregnancy after 12 months or more of regular unprotected intercourse. Incidence is 10 to 15%. And earlier evaluation is needed in patients for whom age is more than 35 years, those who present with menstrual irregularity, and in whom there is diagnosed and suspected male subfertility factor, and stage 3 and 4 endometriosis or uterine or tubal pathology. So, subfertility may be a result of one or more male or female factors. So, male and female factors are equally responsible, around 30 to 40% each. So 20%, in 20% of the cases, there is combination of both the factors. So evaluating both the partners is mandatory. So now we go on to the risk factors of female subfertility. So under which comes the patient's age, stress, poor diet, smoking, alcohol, substance misuse, overweight, both overweight and underweight, caffeine intake, too much exercise, STDs, endometriosis. So as the woman's age increases, the ovarian reserve and the pregnancy rates start declining from the age of 30 years. And there is a sharp decline after 35 years of age. So those patients whose BMI is more than 29 will take longer to conceive. And those patients whose BMI is more than 29, along with anovulation, so losing weight is likely to increase their chance of conception. So now we go on to the causes of subfertility. So the main cause which contributes 30 to 40% to the female subfertility is ovarian cause, under which comes the anovulation, corpus luteal insufficiency, primary ovarian failure, decreased ovarian reserve, everything. So the next most common cause is tubal factors, under which comes the tubal infection, pelvic endometriosis. Next would be the uterine factor, which contributes to 10% of infertility. In uterine factor, we will discuss about the fibroids, synecdoche, congenital malformations of uterus, chronic endometriitis. And in pelvic causes comes the endometriosis and adhesions, which will affect the tubal motility, plus it will cause anovulation also. So the causes for female subfertility can be broadly put under all these headings: decreased ovarian reserve, ovulatory factor, tubal factor, uterine factor, pelvic factor, and unexplained infertility. So evaluation includes, first of all, proper history taking, which takes into account the duration of married life, cohabitation period, coital frequency, occupation, past treatment history, everything. So next comes the evaluation part. Under evaluation of ovaries comes the measuring the ovarian reserve using antral follicle count by ultrasound, serum AMH, anti-Mullerian hormone, serum FSH, and ovulation can be tested by basal body temperature method, mid-luteal progesterone levels, urinary LH, endometrial biopsy, and transvaginal ultrasound. So, and fallopian tubes can be evaluated using hysterosalpingogram, saline infusion sonography, and laparoscopy with chromoperturbation. Evaluation of uterus can be done using normal ultrasound, hysterosalpingogram, hysteroscopy, and 3D ultrasound. And not to forget the baseline day 2 profile of FSH, LH, TSH, and prolactin, because hyperprolactinemia will affect ovulation, subclinical hypothyroidism will affect implantation, and it is always better to know the baseline FSH and LH basically to classify the causes of anovulation. So the under ovarian factor, anovulation plays a major role. So we can classify anovulation into 3 classes. WHO class 1, under which comes the hypogonadotrophic hypogonadism, where the FSH-LH is reduced and the estradiol is also reduced. In these cases, pulsatile GnRH therapy will help us. Under WHO class 2 comes normogonadotrophic, normoestrogenic anovulation, like PCOS. So ovulation induction will be the treatment of choice in this class of patients. And under WHO class 3 comes the hypergonadotrophic hypogonadism, where FSH is elevated and estradiol level is low. Example, ovarian failures. So management would be IVF with donor oocytes in such cases. So hyperprolactinemic anovulation can be treated by giving cabergoline and bromocriptine to suppress prolactin. So under anovulation, the most common endocrinopathy in reproductive age is PCOS. 5 to 10% of women in the reproductive years are affected by PCOS, and it contributes to 39 to 40% of female infertility. The features of PCOS are menstrual dysfunction, anovulation, hyperandrogenism, insulin resistance, and type 2 diabetes. So the diagnostic criteria which we use is Rotterdam criteria, which includes the polycystic ovaries by ultrasound showing 12 or more peripheral follicles, oligo or anovulation, hyperandrogenism, clinical or biochemical. So any 2 of 3 criteria is enough to diagnose PCOS. So little bit of pathophysiology of PCOS we'll discuss. The main pathology in PCOS is insulin resistance leading to hyperinsulinemia, which increases the androgen level directly from ovary and adrenals. It inhibits sex hormone binding globulin synthesis, which leads to high free androgen level. There will be an indirect rise of androgen due to high LH. So hyperinsulinemia and hyperandrogenism causes anovulation and late sequel of PCOS. So management of PCOS begins with the lifestyle modification and weight loss of 5 to 10% at least. And the management would be ovulation induction with letrozole, the first line drug, followed by clomiphene. If not responding, we can add insulin sensitizers like metformin, and followed by gonadotrophins. And as a last resort, we can go for laparoscopic ovarian drilling. So individually, letrozole is the first line drug. It inhibits aromatase enzyme in granulosa cells. It prevents the conversion of androgen to estrogen, blocking the negative feedback mechanism, increasing FSH, which leads to follicular development. The main advantage of letrozole is that it has a short half-life, rapidly eliminated, and results in monoovulation. There is no anti-estrogenic effect on endometrium and cervical mucus like clomiphene citrate. So clomiphene citrate is a non-steroidal SERM. It binds to hypothalamic estrogen receptors. It blocks the negative feedback effect of circulating estrogen. It is specifically useful in those PCOS patients whose BMI is more than 30. And clomiphene resistance is defined by failure to achieve ovulation with highest possible permissible dose. And clomiphene failure is defined by failure to conceive after 3 cycles of clomiphene citrate with documented ovulation. So in case of clomiphene resistance, we go for alternative drugs like letrozole, tamoxifen, gonadotrophins, etc. In clomiphene failure, we have to proceed with laparoscopic ovarian drilling. Laparoscopic ovarian drilling improves ovulation, it reduces LH and reduces the insulin resistance. The indications for laparoscopic ovarian drilling are the clomiphene resistance, LH, hypersecretion, and ovulatory PCOS. Best results are seen in first 6 to 9 months post-procedure. Next comes the premature ovarian insufficiency, defined by loss of ovarian activity in less than 40 years. So it's characterized by menstrual disturbance, amenorrhea, oligomenorrhea, raised gonadotrophins, and low estradiol level. So primary ovarian insufficiency is nothing but hypergonadotrophic hypogonadism. The causes can be causes are chromosomal defects like Turner syndrome, Fragile X premutation, autoimmune processes, chemotherapy and radiation-induced gonadal damage, infections, endometriosis surgery affecting ovarian reserve, and most common is idiopathic. And primary ovarian insufficiency criteria, there are two criteria: oligo or amenorrhea for at least 4 months, elevated FSH level more than 25 international units per liter on 2 occasions 4 weeks apart. So the management would be IVF with donor oocyte. Next, we'll deal with the tubal factors. Factors which impede the descent of a fertilized or unfertilized ovum into the uterus through the fallopian tubes. So the PID, endometriosis, history of septic abortion, ruptured appendix, tubal surgery, previous history of ectopic pregnancy causes obstruction, damage, and scarring of the tube. So the embryotoxic properties of the hydrosalpinx fluid alters the endometrial receptivity and causes mechanical hindrance by washing out embryo. So salpingectomy and proximal tubal occlusion are recommended before IVF treatment. And most of the all tubal factors will be treated by IVF. So now we'll move on to the uterine causes, which contributes to 15%. And the causes are endometrial polyps, submucous myomas, intrauterine synechiae, endometrial hyperplasia, and congenital anomalies of uterus. So all these problems can be addressed well with hysteroscopy. And the diagnosis, for the diagnosis part, HSG and transvaginal ultrasound helps a lot. So treatment of the cause would be the solution. So endometrial polyps, in case of endometrial polyps, we'll do hysteroscopic polypectomy, and submucous myomas can be removed hysteroscopically. For intrauterine synechiae, we'll do synechiolisis followed by hormonal suppression. And for congenital anomalies like septate uterus, we should do hysteroscopic septal resection. So Mullerian agenesis patients can have genetically related children only through IVF and surrogacy. Hysteroscopic septal resection significantly reduces the rates of pregnancy losses but not infertility. So briefly about uterine fibroids, all fibroids will not cause infertility. Submucous myoma is the bothersome one, which alters the uterine contractility and it impairs the gamete transport and causes endometrial distortion. So removal of intramural fibroid, which is distorting the cavity, and submucous myoma should be done before infertility treatment. So we'll discuss something about the luteal phase defect. It's insufficient progesterone production to maintain a normal secretory endometrium. So it's defined by luteal phase shorter than 10 days, a gap of more than 2 days in the endometrial histological dating compared to expected day of cycle. So the incidence is 3.5 to 13% in infertile patients, 32 to 35% in recurrent miscarriage patients. The incidence in gonadotrophin stimulated cycle ranges from 12 to 30%. And it should be suspected in patients of unexplained infertility, advanced maternal age, recurrent abortions, turnovers exercise, underweight or recent sudden weight loss, secondary amenorrhea, hyperprolactinemia, and hypothyroidism. So the diagnosis is by timed endometrial biopsy. More than 2 to 3 days out of phase should help in diagnosing luteal phase defect. The preferred time for endometrial biopsy is between 6 to 10 days post-ovulation, as it coincides with window of implantation. Not to overdiagnose luteal phase defect, 2 biopsies should reveal similar picture histologically. The management would be progesterone supplementation in the luteal phase. It should be supplemented 4 days after detection of urinary LH. Very early introduction of progesterone can suppress periovulatory cervical mucus. So luteal phase insufficiency depends upon the trigger used for final oocyte maturation also. So GnRH agonist trigger will cause profound luteal phase defect. Recombinant LH will cause intermediate luteal phase defect, and HCG the least luteal phase defect. So now we'll discuss about another important cause of endometriosis, cause of subfertility, endometriosis. It's an inflammatory disorder characterized by the presence of endometrial glands and or stroma in sites other than uterine cavity. So the incidence is 10 to 15%, and 30 to 50% of patients affected by endometriosis suffer from subfertility. In mild to moderate disease, there is impaired uterotubal transport of sperm, ovulatory disturbance, subtle impairment of oocyte and embryo quality, implantation defects, anti-endometrial antibodies, progesterone resistance, and increased risk of recurrent miscarriage. In severe disease, there is distorted tubo-ovarian axis along with the above mentioned factors. So the management depends upon the patient's age, ovarian reserve, previous pelvic surgery, under associated pain, malignancy suspicion, disease extension, and mean diameter of the lesion. If the mean diameter of the lesion is more than 4 cm, it's better to proceed with cystectomy for a better gonadal response to stimulation and access to the follicles and histological diagnosis. So the management after surgery can be expectant in less than 35 years of age with good ovarian reserve patients. When the age is more than 35 years and there is decreased ovarian reserve, better to proceed with assisted reproductive technologies. So the management can be grossly divided as stage 1 and 2 endometriosis, less than 35 years, expectant management can be given, or superovulation with or without IUI can be done. Intrauterine insemination can be done. In more than 35 years, superovulation plus intrauterine insemination or IVF can be done. So in stage 3 and 4, IVF should be provided. So the endometriosis management guidelines says operative laparoscopy, including adhesiolysis, rather than performing diagnostic laparoscopy, only in infertile women with stage 1 and 2 endometriosis to increase ongoing pregnancy rates. The excision of the endometrioma capsule instead of drainage and electrocoagulation of the endometrioma wall to increase spontaneous pregnancy rates. Counsel the woman with endometrioma regarding the risk of reduced ovarian function after surgery and the possible loss of ovary. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgery. So IVF for infertility associated with endometriosis, especially if tubal function is compromised or if there is a male factor infertility and or the other treatments have failed. So the last topic which I cover would be unexplained infertility. The incidence is 15 to 30%. It's a diagnosis of exclusion. Semen analysis, test for ovulation, assessment for tubes and uterus will be normal, but not yet conceived after 1 year of unprotected intercourse or 6 months if more than 35 years of age. The possible causes of unexplained infertility are increased phagocytic activity of peritoneal leukocytes, tonic increase in LH, luteinized unruptured follicle, abnormal peristaltic movements, and loss of ciliary activity of fallopian tube. Altered T helper cells ratio can be a cause, and high sperm DNA fragmentation can be the possible cause. And the management, we can do a expectant management with lifestyle changes, induce ovulation induction with clomiphene citrate, superovulation with IUI and IVF. Again, the management depends upon the age of the patient, duration of married life. So unexplained infertility with age less than 35 years and duration of married life less than 2 years, expectant management can be given for 2 years, followed by gonadotropin stimulated IUI for 6 cycles, followed by IVF. If the duration of marriage is more than 2 years, HMG stimulated IUI can be given for 6 cycles, followed by IVF. So when the age is between 35 to 39 years and the duration of married life is more than 1 year, better to go ahead with HMG stimulated IUI for 3 to 4 cycles, followed by IVF. When the age is more than 40, irrespective of duration, HMG stimulated IUI can be given for 2 cycles, followed by IVF. So the take-home message is, to summarize, the management depends on so many factors like age of the patient, ovarian reserve, duration of marriage, semen parameters, and past treatment history. And it will be like individual management differs. Thank you. Any doubts? Any doubts can be asked. Because it is a vast topic, I have covered, presented it very precisely. So any doubts anyone has can put in chat box. Thank you. Am I audible?
Yes, ma'am, you're audible, ma'am.
Okay. Hello.
Thank you, ma'am,
Now-
for the elaborative and informative talk. Next, I request Dr. Jyoti Mary Fuller to introduce our next speaker, Dr. Sebanti Das. Dr. Sebanti Das is the Chief Embryologist and Managing Director of Srishti Hospital, Pondicherry. She has completed her training in embryo biopsy and peri-implantation genetic screening and laser hatching. In a career spanning for more than 10 years, she has done more than 15,000 intracytoplasmic sperm insemination, and she has always been keen to keep herself updated in learning new skills. Many firsts in Pondicherry in the area of reproductive medicine were possible because of the constant endeavor of the team to do the best for the couples. First, frozen embryo transfer, first testicular sperm aspiration ICSI pregnancy, first pregnancy with vitrified oocytes, and so on. She has also helped set up new IVF labs in India and abroad. The next milestone is to be achieved is starting the services for embryo biopsy and PGS in Pondicherry. We are happy to have you, ma'am. Over to you.
Thank you so much. To share my.
Yes, ma'am. We are sharing the slides from our side, ma'am.
Okay, fine. Thank you. Thank you, sir. Good afternoon, everybody. First and foremost, I'd like to thank Lakshmi ma'am and the entire organizing committee for the CME and also the management of AVMC for giving us this opportunity to speak regarding our experiences in reproductive physiology and reproductive medicine. The best part is to see many familiar faces and see many familiar names, which is a boon during these times of social distancing. So without my talk, bench to bedside in reproductive physiology, I have been given the topic on embryo transfer and storage. So I like to call it from in vitro to vivo. Could I get the next slide, please? We all wish that we could do this, you know, make the baby in the test tube, gift wrap, and hand it over to the parents. But no, it is not possible to do that. So embryo transfer, which is an important component, important procedure for infertility, that is one of the central procedures which we do in case of subfertility treatment. Can I get the next slide? Dr. Sashikala has spoken in quite some detail regarding the causes and of course on the treatment options which is offered to the patients of subfertility. Now, I like to classify them into two types. That is treatment in which the fertilization occurs inside the human body. So there are two types, mainly the timed intercourse and the intrauterine insemination or IUI. Another set of treatments in which fertilization occurs in the laboratory. So there are two types in that. One is in vitro fertilization and intracytoplasmic sperm injection or ICSI. The next slide, please. This is a schematic diagram of what exactly happens in IVF or ICSI. Of course, we pick up the oocyte from the ovaries under ultrasound guidance. And then in the IVF lab, we perform the procedure of ICSI or IVF to fertilize the oocytes. And as you see, the embryo development goes on from pronuclear stage to a 2-cell stage to a 4-cell stage to an 8-cell stage, and of course to blastocyst and further, which is not shown here, which again is replaced back into the uterine cavity. Next slide. This is just a diagram to show you the difference between IVF and ICSI. In IVF, they just release the sperms along with the oocyte in a culture medium. The sperms naturally select and go and fertilize the oocytes. Whereas in case of ICSI, the selection of sperms and the injection into the oocyte is in the hands of the embryologist. Next slide. So what is embryo transfer? As I told, it's a crucial step in the procedure of assisted reproductive technology. Without replacing what we are forming in the lab, a conception cannot occur. So, and it is also a step where they say that science meets art. Okay. Now, how I'll explain the statement in my further slides, why we are calling it an art. There are other expressions also which are used instead of embryo transfer. They also refer to it as embryo replacement or egg transfer, which is not the most accurate of terms. Pre-embryonic transfer is mainly used for embryo transfers in the cleavage stage, that is 4-cell stage or a cleavage stage at day 3. And of course, blastocyst transfer, which is a transfer of the embryo, which is already grown to a blastocyst at day 5 or day 6 stage. Next one, please. So I'll be talking about embryo transfer under the following headings. Methods for transfer of the fertilized oocytes, placement of embryos, fallopian tube versus uterine cavity, placement at various positions in the uterine cavity, day of the transfer, transfer media, types and volume, transfer catheters, number of embryos for transfer, and fresh transfer or remote transfer. So what are the methods for transferring of fertilized oocytes? The gold standard or the method which is followed by most clinicians is the trans-cervical intrauterine embryo transfer. So we follow the natural path, like instead of the semen entering into the uterine cavity, we are directly injecting the embryo into the uterine cavity through the cervical pathway. But there are also many other methods. These methods are not very frequently used because they are sometimes more interventional or invasive than the trans-cervical method. And certain situations, they are used when the approach to the cervix may not be convenient due to some anatomical abnormalities or some other reasons like infections or something. So the other methods of transferring embryo are the transmyometrial embryo transfer. Now this can again be done through the vagina entering with the help of a needle, pricking the myometrium and depositing into the endometrial cavity, or it can be done laparoscopically. And similarly, surgical transfer, which also can be done laparoscopically. Placement of the embryos. So where do we place the embryos? Do we place them in the fallopian tubes, where actually physiologically the fertilization occurs, or do we place them in the uterine cavity? Various methods have been used around the entire history of assisted reproductive technology so far. The initial idea was to transplant it back into the fallopian tube because that was more physiological. And as you should understand that in the initial days of IVF, growing to further stages, that is growing beyond day 3, day 4, day 5 were not possible because the media which we used during those times were very simple media, and they were not supporting the growth till the advanced stages of the embryos. So the embryos were transferred back at much earlier stages, and therefore the preference for the clinicians were transferred back into the fallopian tube, which is the more physiological environment for a 2-cell to 8-cell embryo. Now, this transferring back into the tubes was either done laparoscopically, or later on a transvaginal method also was in practice, in which a long catheter was passed through the cervix, through the uterine cavity, into the tube, and then the embryo was deposited there. But you should understand that that was a much laborious method because you have to pass a long distance to transfer the embryo. For the same reason, because of the laborious method of it and because of the invasive nature of the procedures, GIFT, that is gamete intrafallopian transfer, and zygote intrafallopian transfer are also obsolete techniques. Now, I have told that the best thing is to transfer it in the uterine cavity. Now, again, the question comes, where in the uterine cavity? Whether we should transfer it more near the fundus or whether we should transfer it more towards the cervix. So initial times, people preferred transferring more near the fundus. Then as the years went along, people realized that touching the fundus was causing a lot of uterine contractions and there was a chance of embryo expulsion. Also, touching the fundus and replacing the embryo might make the embryo flow into the tubes and can result in an ectopic pregnancy. So as the years went by, more and more people started advocating to replace the embryos further down into the mid cavity. Right now, actually, we do a ultrasound guided mid cavity transfer, which is little bit towards the lower part of the mid cavity and not towards the higher part of the mid cavity. There is also a method how to calculate the point of maximal implantation potential, but I will not be going into the details of those. Now, if you see the, please go back to the previous slide. Yeah. So if you see the picture which I have put, they are showing that the catheter is being inserted through the uterine cervix and has gone into the mid cavity. And the lower part of the picture shows the ultrasonogram image of the placement. If you see, there's a white dot in the central part of the cavity, which is actually where the embryos have been deposited. Next slide, please. Now, again, this is a very, very controversial topic. Even now, when we go for conferences on ART techniques, there is always a topic on whether day 3 or day 5. That is whether to transfer cleavage stage embryos or to transfer the blastocysts. Actually, throughout the history of IVF, gametes have been transferred, zygotes have been transferred, cleavage stage embryos have been transferred, blastocysts are being transferred now, and also people have tried transferring hatched blastocysts. The idea of transferring, more and more people are advocating transferring of a blastocyst rather than transferring of a cleavage stage embryo, because right now the gold standard is to transfer the embryo into the uterine cavity. And it is a blastocyst which reaches the uterine cavity, not the cleavage stage embryo. So transfer of a 2 to C-still stage into uterine cavity is not a physiological way of doing the transfer. Rather, a day 5 or a day 6 blastocyst transfer is advocated and it is placed in the mid-uterine cavity. Another advantage of doing a delayed transfer, before that, like I told you, initially the media which was being used were very simple media, and they were not supporting growth till day 5, day 6, and the embryos were getting damaged. Therefore, earlier transfers were being made. But now the media which is available to us support the growth of the embryos up to day 5, day 6, or even through day 7. So transferring late is never an issue right now. Another advantage of transferring embryo at a later stage is that we do have now what is called a pre-genetic screen. So we can take one of the blastomeres and do a genetic screening on that. And this is mainly offered to those couples who already are known to have some inherited diseases, or they are having recurrent implantations to find out if there are any mutations. Now, if we want to do a genetic screening, we can do it on a day 3 embryo and wait for the embryo to go till day 5, in between which we can always get the reports of which are the blasts which are of good quality, which are the blasts which are not good quality, which have the inheritable mutation, which don't have, and accordingly transfer. But now we are doing PGS also on blastocysts. So what do we do about that? If we take a blastomere from a blastocyst and do a PGS, then the only option is to do a vitrification, that is, freeze the blastocyst and transfer it in the next cycle. Few other concerns which have been talked over for years now is the time of the day when the embryo transfer should be done. They have done transfers during the daytime, they have done transfers during the nighttime. In fact, in the initial stages of IVF, transfers were done only during the nighttime to prevent, they say the uterine contractions are less during the nighttime, but studies, extensive studies have found no difference in the implantation potential or implantation rates of transfers done during various times of the day. So it doesn't matter at what time of the day the transfer is being done. Another important thing which often patients ask, and specifically now that I have been working in Pondicherry for so long, the question which they come and ask is during the Agni Nakshatram, that is the heat time when the summer is in peak, April, May, June months, whether they should go ahead for IVF or not. Again, it has been found through extensive studies that seasonal variation, at least in human beings, is not there regarding the implantation potential of an embryo or the implantation potential of the endometrium. So what do we transfer the embryo in? What is the media which we use for the transfer of embryos? Most of us embryologists use the same media which we use for culturing. The media which supports the culture of the embryo till the blastocyst, the same media can be used to transfer back the embryo into the uterine cavity. In certain patients, mainly patients with recurrent implantation failures or patients who have had recurrent abortions, they do suggest to use another kind of media which is enriched with hyaluronan, which is supposed to be a very viscous media and supposed to cause attachment to the endometrium and thus prevent any kind of embryo expulsion, enhance the endometrial receptivity, and cause enhanced implantation. But again, this media is not too much in use. Their studies are still going on as to really the efficacy of the media. How much volume of the media should we use? In the initial years of IVF, a huge volume of media was used to place the embryo inside the uterine cavity, almost 150 microliters. But the disadvantage of such a huge volume is that the embryo can very easily flow into the tubes and either expel out through the femoral end or settle into the fallopian tube and cause an ectopic pregnancy. So over the years, lesser and lesser volumes have been loaded into the catheter or the embryo transfer catheter. And now what is the gold standard is loading approximately around 15 to a max of 25 microliters, and the embryo is injected only with that volume so that there is no outflow towards the tubes. Now, if you see the diagram which I have put, can I just go to the previous slide? Yeah. If you see the diagram which I have put, there are different methods of loading the embryo catheter. Okay. In group A, if you see, the entire catheter is full of fluid. Only at the tip of the catheter, the two embryos are present, which is in the 10 to 15 microliter fluid. That is one method. The other method, which is more frequently used by most of us embryologists, is called the sandwich method. We have a small volume of media followed by a small air bubble. then a small volume of media with the embryos of the blastocysts, and then another air bubble, and it is the tip of the catheter is sealed by a little volume of the media. Now, the advantage of this kind of loading is when you discharge the embryos into the uterine cavity, it is very well seen under the ultrasound because the media appears to be white and the air bubbles appear to be darker. So you can very well see where exactly you are placing the embryos. Now, transfer catheter. Transfer catheters, there are too many technicalities. If I have to go ahead and talk about the transfer catheters, and I don't think we have a scope of that in this particular discussion, but there are certain points which I like to put forward through to you. There are numerous models of catheters available in the market right now, depending upon their length, their diameter, their shape, the ability to be seen under ultrasound. So there are a few points which I noted down as to what an ideal embryo transfer catheter should be. First is it should be soft and flexible. Now, why? Because it should not, when we are inserting into the endometrium, it should not damage the endometrium in any way. The second desirable quality of an embryo transfer catheter is that it should be non-embryotoxic. That means it should be made of a material which doesn't affect the embryos in any way. The third is that it should be free of any kind of bacterial endotoxins. That should be a sterile catheter so that when we are passing the embryo into the uterine cavity, we are not passing some amount of infection along it. Of course, the shape of the intrauterine catheter should be such that it should have an ease of introduction into the uterine cavity. As you see in one of the pictures, there's a slight curve. So that is easier. As you know, the uterus is not straightly placed on the cervix. There is an anteflexion. So because of that, the curve has been given for easy insertion into the uterine cavity. Also, if you see, look closely at the same particular picture, you'll see there are some gradation markings at 1 centimeter level. Now that is to assist the clinician to know how much inside the uterine cavity he has already gone. So he makes it sure that he is neither too low nor too high a placement of embryos occur. Last but not the least, the embryo catheters which are available now should definitely be visible on ultrasound, because all embryo transfers ideally should be performed under ultrasound guidance so that you know the exact position of the placement of the embryos. Now, when I had mentioned that embryo transfer is more of an art than a science, I said that because over the years, with so many models of embryo catheters being available in the market and so many studies having been done as to which catheter is better and which catheter is giving better results, the final conclusion of all the studies was it is not the type of the embryo catheter which we are using which improves or enhances the pregnancy rate, but it is definitely the skill of the clinician who's placing the embryos. How atraumatically, how easily, how fast he can do the procedure, and how accurately he can place the embryos in the proper position is all that makes a difference to the clinical pregnancy outcome. Now, another controversial topic in embryo transfer is how many number of embryos should be transferred in one sitting. Historically speaking, IVF was done only in natural cycles. In those times, availability of gonadotropins for stimulation of ovaries was not available. So what was done was, in a natural cycle, single oocyte was harvested from the lady, and that one oocyte was fertilized and the single embryo was replaced back. But over the years, as improvement in ART techniques have occurred and availability of more and more amount of drugs are there for us, what we are right now doing and what has been being done for the last 10 to 15 years is called a controlled ovarian hyperstimulation. This is again a long topic, which is not in the scope of this particular embryo transfer topic. But what you should understand is we can give gonadotropins, FSH and LH, so that at one particular time, not one, but many oocytes develop, many follicles develop, and we can get many mature oocytes from those follicles by oocyte aspiration. What is the advantage of getting more number of oocytes? The chance of pregnancy are increased because you're forming more embryos out of those oocytes. Now, initially what people were doing when the cryopreservation was not a standard protocol and people were still undergoing trials of cryopreservation. Cryopreservation methods were not so perfected, they were damages. So what most of the clinics, what clinicians were doing is they were transferring as many embryos as possible in the first sitting to give the best clinical outcome. In fact, up to 5-6 embryos at one time were transferred into the patient. Now, what is the flip side of transferring so many embryos? Multiple pregnancy. As we know, multiple pregnancy has side effects on the mother as well as on the child. You might have read so many news articles where they tell that a lady has delivered 6, 8, 9, 10, but really that's not the desirable thing. What we look at now is to give a single healthy baby to the couple. So the present recommendation is 1 or 2. I have written as embryos, but what actually we should do is a maximum of 2 blastocysts should be transferred in one sitting and not more than that. Actually, in some countries, mostly in the Northern Europe, the Nordic countries, it is illegal to transfer more than 1 embryo in a single setting. Single embryo transfer is the norm in those countries. Of course, the norms are a little more relaxed in India, but with the new ART guidelines coming on, so they are also going to tighten the rules as to the number of embryos which you can transfer in one sitting. Now, you may be having a question, okay, we were transferring 5 embryos, 6 embryos, and definitely we were getting a good pregnancy because at least 1 or 2 of them will implant. So now when we're transferring only 2, how are we improving the pregnancy rates? What we are looking at now is the pregnancy, a cumulative pregnancy rate over multiple embryo. We're transferring 2 to give a balance. If 1 also implants, the patient is going to have a baby. Suppose in the present setting, she has not conceived, we have extra embryos stored with us, which can be subsequently transferred in other cycles, in remote cycles as frozen embryo transfers. And what has been found is the cumulative pregnancy rates are just as good, and there is no decrease in the cumulative pregnancy rates by decreasing the number of embryos or blastocysts transferred in one setting. Now, this is another decision which needs to be taken every day whenever we are doing oocyte retrieval from a particular patient. The decision whether to transfer the embryos in the fresh cycle, that is in the same, we do oocyte retrieval, we grow the embryos to blastocyst stage and transfer it back to her on day 5. That is called a fresh embryo transfer. Or whether we should do a remote embryo transfer. That is, we have done the oocyte retrieval this cycle, and then we grow the embryos, we vitrify them, store them, and later on, maybe the next cycle or next to next cycle, whenever the patient parameters and her endometrium is okay and perfect to go ahead for embryo transfer, we transfer it back. There are many, many reasons based on which we decide whether it should be a fresh transfer or a remote transfer. The first important deciding criteria is what is the triggering agent which we have given. Now here I have to mention that when the patient is ready after 11 to 12 days of giving FSH and LH injections, we give a trigger to mature the oocytes. It's an ovulation trigger actually. So in certain cases we give HCG. It may be a urinary HCG or it may be a recombinant HCG, or in certain cases we give vucerin, the HCG and LH diagonist. Now when we are giving an HCG trigger, we can go ahead and transfer the embryos in the fresh cycle. But if we are giving vucerally, then we have to go ahead and do a remote transfer. Next is the hormonal status of the patient. Before giving the trigger, what we do is we see the levels of estrogen and progesterone for the patient and see what are our estrogen levels and progesterone levels pre-trigger. If our progesterone levels are more, there are set criteria for that, like more than 2. Then we will not transfer the embryos in the same cycle because endometrium will not be receptive. It has gone more towards the secretory stage. If it is less than 1, if she doesn't have too many number of, if she's not been triggered by buserelin, if the ovaries are not too large, everything is fine for her, we'll go ahead and we'll transfer back embryos in the fresh cycle. There may be, even if everything is all right, hormones are okay, everything is fine, but there may be certain endometrial conditions when we can't transfer back the embryo in the fresh cycle. The endometrial conditions may be, she may be having some polypoidal endometrium, or she may be, the endometrium might have already gone to a secretory stage, or she may be having some kind of breakthrough bleeding. So in these cases, we will not go ahead and do the embryo transfer in the fresh cycle. We'll rather do a remote transfer. Now, one thing which I need to point out here is, for the remote transfer, what is definitely required in a center is a robust cryopreservation program. Many centers are having it now, but there are still many centers which don't have a robust cryopreservation program. Now, why I'm telling a robust cryopreservation program is because cryopreservation, again, is a very, very difficult skill to acquire. And if not done properly, it will cause damage to the embryos or the oocytes, whichever is being stored. So the cryopreservation program, if it is good, you get back intact embryos after thawing the embryos. They can go ahead and give pregnancies without, just like transferring in the natural cycle. Now, there are some questions which patients who have undergone embryo transfer, they ask us. There are so many myths, there are so many misconceptions, there are so many social problems. And I know that Dr. Gopinath has spoken about stress. So post-embryo transfer, not only during the entire period of stimulation, but post-embryo transfer, we wait for at least 14 days, 12 to 14 days to see her HCG levels, to find out if she has conceived or not. And those 12 to 14 days can be a really stressful period for the woman, because it's like the exam results. You're waiting for the exam results. So patients ask us whether they can walk after the embryo transfer. Many studies have been done regarding early ambulation after embryo transfer. During the earlier stages of ART techniques, they were advising patients to take rest for 24 hours, 36 hours, 48 hours, 3 days, because there were no studies to tell us definitely whether. The fear is that the position in which the embryo has been placed will move. The embryo will move down, may get expelled through the cervix, or if the patient is lying down in a different position, the embryo will move towards one of the tubes or move towards the fundus. But many studies have been done which have proved that the position in which the embryo has been placed hardly changes due to position of the patient. Maybe 1 millimeter up and down, but not more than that, doesn't get out, expelled through the cervix. So what in our center also, we advise patients for early ambulation. In fact, the standard protocol is now to give them half an hour, maximum 30 minutes of bed rest before they are told to change. And we don't advise patients to take a 14-day bed rest without moving out. They are told to do their normal physical activity even after embryo transfer. See, logically speaking, when a woman conceives naturally, she doesn't even know it. And that 14 days or initial 2 to 3 weeks, she is totally unaware of the fact that she has conceived, and she continues doing her normal activity. She continues doing her normal work. She continues sleeping in whatever position she's used to. That doesn't affect her pregnancy. Same thing applies for IVF also. There's no difference in this. So we advise patients to continue the physical activity, more so because physical activity in her natural surroundings and a normal behavior without too much of restrictions keeps her stress-free. And stress is an important factor which does affect implantation. Complete bed rest is total no-no, not only because it restricts the patient a lot, causes a lot of stress, and also because as a method of endometrial support, we give progesterones. And as you know, progesterone can cause a lot of constipation. So to prevent that also, we tell the patient that should not be on complete bed rest, should do their normal physical activity. In fact, go out for a short walk every day morning and take the usual exercise, not very heavy exercise, but do her usual exercise, which she does every day. Another important question which is often asked is regarding sexual activity in the peri-embryo transfer period, that is before the embryo transfer and also after the embryo transfer. Many studies have proved that sexual intercourse in the peri-embryo transfer period actually enhances the implantation due to some chemicals which are present in the semen, but there are not too many recent studies regarding this. We, of course, tell the patient to avoid sexual activity post-embryo transfer, that is just to prevent any kind of infection which the patient can have. Only because of that reason, we ask them to avoid embryo transfer, ask them to avoid sexual activity after embryo transfer. A very, very prominent question which comes to us from all patients, their relatives, is what food they should have. There is no restriction on food. The patient is told to have her normal food, whatever she has on a regular basis, that she should suddenly become a vegetarian, she should suddenly become a vegan, nothing of that sort. She has to continue taking whatever she takes. Food, any kind of food doesn't affect the implantation in any way. Sleeping position, like I told, patient wanted to know whether she can sleep on her left, whether she can sleep on her right, whether she can use a pillow. No, these things don't make a difference to the implantation potential of the embryo. She should be free to do whatever she feels like. And the last point is about stress and relaxation, which I think has been talked in detail by Dr. Gopinath, and I will not go too much into it, but definitely we also advise patient to remain as much stress-free as possible, go back to her work and not be on leave at home if she's a working woman. Go back to her home and perform her daily routines, because that takes the mind off the beta HCG results. So it keeps her much more stress-free post-embryo transfer. The second part of the talk is regarding the storage of embryos. Cryopreservation is a very, very important procedure in the modern world, because there are many situations where we do a remote transfer of blastocysts. Not only do we cryopreserve embryos, blastocysts, but we also cryopreserve oocytes, that is to use it at a later date. We also cryopreserve sperms. In fact, there are certain higher institutions who also cryopreserve ovarian tissue in case of patients undergoing chemotherapy. So all these things are already there. Now, there are two types of cryopreservation. One is called slow freezing and one is called vitrification. Slow freezing was the procedure which was performed even, I think, around 5 to 6 years back. But now I think all centers have switched over to vitrification, because there were many disadvantages of slow freezing. First disadvantage, it takes a long time. And therefore, the person who's working, the embryologist, has to be there for a long time to cryopreserve the embryos. And that actually, because that is not the only work the embryologist will be doing that day. There are many other works. So the person is held up there. You need many more personnel in the IVF lab, or one person has to be held up for only doing this. And the second most important thing was the recovery after slow freezing was not that good. Many of the embryos were found to have cryo damage. So the other method for cryopreservation, which was worked upon and which is right now the gold standard, is called vitrification. So vitrification can be defined as a method of rapid freezing which prevents the formation of ice crystals. As we all know, intracellularly, there's a lot of water. Now, if you're freezing it in ice crystal forms, it damages the intracellular organelles, as well as when we are thawing, it damages the cytoplasm and the cellular membrane. So the prevention of ice crystal formation is the most important thing which has to be taken care of. So it's a rapid freezing, but it prevents ice crystal formation. So the tissue, it solidifies into a glass-like structure without having any crystallization. That is the most important thing. Now we do vitrification under liquid nitrogen. And the vitrification process is so fast that the temperature of the embryo or the blastocyst decreases from 37 degrees centigrade, which is the normal body temperature, to minus 196 degrees centigrade in less than 1 second. Now, how can that be done? That can be done because we have to use cryoprotectants. What are cryoprotectants? Cryoprotectants are substances which prevent the ice crystal formation inside the cell. There are many cryoprotectants which are available in the market. Various combinations of cryoprotectants are available in media from different brands. But the most important things which are the most common substances which are used are dimethyl sulfoxide, that is DMSO, glycerol, ethylene glycol, sucrose, trehalose, etc. What they do is it's a very viscous kind of a solution. So they sort of little bit dehydrate the embryos and the blastocysts, and also decreases the crystal formation temperature for water. So by the time it goes into the liquid nitrogen, it has no time for the crystal to form. Finally, when we take out those embryos and thaw them, they come back looking just as intact as if no procedure has been done on them. Both vitrification and thawing takes around 12 to 15 minutes. 15 minutes for vitrification, when we keep it stored, labeled in cryocans. And again, when we want to transfer back the embryos to the patient, we have to take out, and that procedure also takes anything between, for some media, 8 minutes, for some media, 10 minutes, for some media, 15 minutes. And after that, we keep the embryos in the culture media in an incubator for it to equilibrate for around 1 to 2 hours before transferring back into the patient. So what are the cryo devices? Yeah, you can put up that slide. The cryo device, you can go to the next slide. I think I'll be explaining on that. As you see, this is a basic procedure, diagrammatic depiction of the procedure of vitrification. In the top part, you see there is a dish on which there's culture medium with the blastocysts on the embryos. Under the microscope, we put the blastocysts or the embryos in something which is called an equilibration solution. From the equilibration solution, the embryos are transferred into a vitrification solution where the time spent is very less. It has to be, and the entire thing has to be done from the vitrification to loading onto the devices, which are the vitrification straws. There are many types of devices also. They are called straws, they are called cryologs, they are called cryotops, they are called cryoleaves. There are many varieties of those also. And a person uses whatever they are comfortable with. There are closed systems and open systems or storage also. So the transfer from the vitrification solution to the cryo device and into the liquid nitrogen, should everything occur within the next 30 seconds. Otherwise, the embryo or the blastocyst is going to suffer cryo damage. Now, where do we store these cryo devices? These cryo devices are stored in cryocans. As you can see in the third picture, they are cryocans of different sizes. The cryocans are filled with liquid nitrogen. And inside the cryocans, we have storage devars and storage canes kind of thing on which we load these cryo devices. In the second picture, you can see that they are taking out a cryo vial, a vial kind of thing. The cryo vial is used for storage of mainly sperms. The cryo vial is being taken out of a liquid nitrogen can, and you can see the amount of vapors which are coming out. So working with liquid nitrogen has to be one has to be very careful, because liquid nitrogen can cause excessive burns, cryo burns. Okay? And the first picture shows a particular type of cryo device. You can see those leaf front, that flattened structure, that is where we load the embryos. Of course, before transferring back the embryos, we have to do a thawing and equilibration, like I had already mentioned. Now, this is one slide which I really like, because if any of you have a chance to come to an IVF lab, you'll see that every work in that is going on in absolute silence. Every person is working at their own workstation. There's not too much of chatter, because there's a lot of concentration is required for doing this work. You should realize everything is under microscope or under the micromanipulator. Okay. So what we say is, work hard in silence, and your success will make the noise. Thank you. anybody has any questions or anything you want to discuss with me? Okay, then thank you.
Hello.
Yes. Hello.
Good afternoon, ma'am.
Good afternoon.
Ma'am, how do you assure the quality of embryo transfers? Is there a way to assess the quality of at the time of implantation or transfer?
Quality of embryo?
I mean, how do you, is there a way to assess the quality of embryo to be transferred?
Yeah, there are various gradations for actually cleavage stage embryos have a different method of gradation of assessing them, like grade A, grade B, depending upon how many number of blastomeres they're having, what are the size of the blastomeres, whether they're equal, they're unequal, and whether there's something called fragmentations, where there are small bits and tissues within the zona pellucida. So there are, on the basis of the number of blastomeres, the size of the blastomeres, and whether the blastomeres are having any vacuolations. And that also we assess at what time we are seeing post-insemination. So whether if it's keeping up to the time limit of its whether it's a slow growing embryo or not. So that depending upon that, we decide regarding the embryo quality. In case of blastocyst, there are many other features which we have to look into. If you look at the structure of a blastocyst, it has a cell lining, a seal in the center, and at the one end there's an inner cellular mass. Okay, so all these structures we look at. We see what is the cellularity of the outer cellular mass, how is the blastocele, whether it is occupying the entire cell, whether it's occupying one end of the cell, and also the inner cellular mass, whether it is tightly packed, whether it has a lot of cells, whether lesser number of cells. So everything together will be put together as grading. So if it is a nicely big blast, okay, on a day 5, we will usually call it as 4. Size of the blast will be 4. If the inner cell mass is tightly packed with a lot of cells, we'll give it a grade A. And also the blastomeres surrounding the blast, if there are numerous of them, we'll again give it a grade A. So the blastocyst will be graded as 4AA, which is an excellent quality blastocyst. Okay. Yeah.
Okay. Thank you so much.
Yeah, thank you. Any other questions anybody has?
If there are no more questions, we'll move on to the next session. Thank you, ma'am. Thank you for your very interactive session.
Thank you so much.
Hello. Yeah, dear delegates, kindly bear with us. Our next speaker is in another meeting. He'll be joining shortly. So as soon as he joins, we will be starting the session. Thank you. Hello, Dr. Jindal. Hello, welcome. Okay, Dr. Jindal, am I audible to you? You're not audible. Dr. Jindal, you are not audible. No, you are muted, I think. Okay. Yeah, you're not audible, Dr. Jindal.
Now, can you hear me now?
Yes, yes, Dr. Jindal, you are very much audible. Okay, shall we start, Dr.
Hello?
Jindal, if you are ready? Yeah. Dr. Jindal, you are audible.
Hello?
Yes, Dr. Jindal, you are audible.
Can't hear.
Oh. You are audible now. Naresh.
Can you hear me now? There is some issue with the WebEx I'm having. It's
Oh,
I just
you are
can't
audible now,
understand what's the problem.
Dr. Jindal, you are audible now.
Just a minute.
Yeah,
just
you
a
are
minute.
audible. Yeah.
Now is it okay?
Yeah,
Can
you
you
are
hear
audible.
me?
Yes, yes, loud and clear.
I'm not getting you. I'll just join in again. I'll just join again. I'll join again. Okay. Can you hear me now?
Yes, Dr. Jindal, you are audible, very much audible.
Fine. I think.
Okay. Yeah. Okay. Can we start now, Dr. Jindal?
Yeah, everything is fine from my side at last.
I'm very sorry that we had to just summon you before your timing.
I understand. I just had to rush from my theater. I'm still in my scrubs.
Yeah, I can see that. I can see that.
And somehow
And
it was a WebEx meeting, which always
Yeah.
creates problems with my system. And I don't know
Oh.
what happens always. So anyway, we now perfect. Thank you very much. Thank you very much for inviting me, madam.
Okay, thank you. And I think we are meeting virtually after a very long time, after our silver jubilee of our
Yes.
batch.
Absolutely.
Yeah. Okay, let us start. I'm very much delighted to introduce my colleague, Dr. Sunil Kumar Jindal from Maulana Azad Medical College. And he's presently, he's the chief consultant, laparoscopic surgeon and andrologist and reproductive medicine specialist of Jindal Hospital and scientific director at Dr. Madhu Jindal Memorial Test Tube Baby Center, Meerut. And he is also the vice chairman of Delhi branch of Indian Association of Gynecological Endoscopists and Indian Society for Assisted Reproduction. And he is also the gold medalist for the best postgraduate from Maulana Azad Medical College, and he has 35 awards to his credit. And he has their center has various collaborations with multiple institutions for research, including American Center of Reproductive Medicine. And he is also national and international master trainer. And they have so many firsts to their credit, like to name a few: first microtessa baby of North India, genetic male giving birth to twins by intracytoplasmic sperm injection technique, and 5 microtessi babies born on the same day, and also giving a baby to the tallest lady of Asia. The child now is 6 feet 9 inches at the age of 13 years and is probably the only surviving child of any woman more than 7 feet 6 inches. And heterotopic cornual pregnancy giving birth to healthy twins. And apart from this, they have the credit of giving given birth to over 6,500 babies by various procedures in the last 18 years. And Dr. Sunil Jindal has written chapters in various textbooks and more than 200 presentations he has made at various national and international forums, and his special interests lie in fertility enhancing and gynecological laparoscopic surgery, reproductive surgery, endolaparoscopic and microscopic andrology surgery, surgical, medical, and laboratory andrology. And congratulations, Dr. Sunil, for your achievements. And now I hand over to you for your session, Past, Present, and Future of Male Fertility. Over to you, Dr. Sunil.
First of all, thank you, Dr. Lakshmi, so much for this kind and extra kind introduction.
And I also forgot that Dr. Sunil Jindal also, their center also has a YouTube channel, and which brings out very interesting videos.
Thank you very much.
Over to you, Dr. Sunil, now.
Thank you very much. So thank you, Dr. Lakshmi, for inviting me to this amazing meeting. And in fact, it's very rarely it happens in my life that I am summoned before the meeting. And I think in the last full year, it's the first time that it's happened that I've had to speak before I had to speak. In fact, I was very bothered. I even messaged to Dr. Lakshmi that I hope we don't go late because at 6 o'clock I have another meeting. But it's nice, I'll be free early. It's so nice. So I was just wanting to talk about the past, present, and future of male fertility, because that would be of great interest to everybody from the point of view of understanding of what actually male fertility is, how physiology is the basis of male fertility, how we today are brighter than what we were before, and how actually a tailor was the first man who started the work of male fertility. It was not a doctor or a scientist. So I'm going to go through that journey with you. I think Dr. Lakshmi has given me 40 minutes or 45 minutes. So that's a reasonable time for me to go ahead with this. I'd just like to share my slides. And of course, I'm thankful to all of you for being here today. And I think I'll be able to add some value to all of you. So I'll just like to share my content. So Dr. Lakshmi, I always have a problem with WebEx, and I don't know why I have it, but it always happens with me. Now, anyway, going ahead with this, if we go into the past, into the ancient Vedic era, and in the Indus Valley civilization, there was a tradition of Niyog Pratha, and it was very prevalent to produce a child. And there were a lot of enchanting mixtures which were made for queens and kings for them to have a baby. So it was a very interesting time over there. In fact, these magic potions were created by sages, and the sages became very, very popular in those kingdoms because of these magic potions. And these magic potions were given to childless queens so that they may have children. And thus the people during that time were aware of some ideas which might be there. But anyway, magic potions were the mainstay during the Vedic period. So if we go ahead further and look into Mahabharata, we realize that there were 5 Pandavas and there were 100 Kauravas. And if you look at those 100 Kauravas, it is a very, very clear mythological saying that those 100 Kauravas were all born in different pots, which could, for that matter, be something like cloning, if I would like to place it in a different fashion. And another very interesting thing is that at that time, if you did not have a baby, you had somebody like Surya gave you a baby, and a princess would summon a god to give a baby. And even at that time, it may have been, though I really do not know, some kind of a gamete manipulation. So if you go through all these things, you realize whether it is those 100 babies born or whether it's baby born because of Surya, there is somewhere or the other that some kind of a gamete manipulation may be taking place or cloning may be taking place at that time. When we go ahead further, we realize that even in our mythology, if we look at the way our gods have been, we would realize that we from our original design have had procreation as the basis of life. So now if you went into the Greek mythology of Hippocrates and Aristotle, you would realize that they said that it is a celestial, I would say it was a celestial thought from somewhere, which would manifest in terms of a baby. But one thing was important to have a baby, that celestial, I would say Ashirvad, or that celestial, I would say blessing, would only come after a couple had copulated. So the importance of a man and a woman being together for the blessing was most important, as per Hippocrates and Aristotle. But something interesting which they said at that time is that once this celestial blessing was there, semen was a fertilizer. So if you look at it in another fashion, today a lot of times we do not allow a husband and a wife, once they are pregnant, to be together. But over there at that time, they thought that semen was a fertilizer. So once the blessing was there, semen was needed to fertilize the baby. Now, as far as William Harvey was concerned, all of you, you must be having a very, very fair idea who was William Harvey. William Harvey was the man of blood circulation. Now, William Harvey at that time said something very interesting. Even at that time, he says something which will be very surprising to you. And that is that a baby is born by a celestial blessing. So even till 1858, 1600s, early 1600s, 1620, nobody knew of how a baby is born. It was not until one tailor who was known as Antony van Leeuwenhoek discovered and made the first microscope. And when he made his first microscope, he saw different things in the microscope. He saw sperms, blood vessels, dental tartar, saw so many things. And whenever he saw all those things, he documented them. In fact, the famous paper of his, which was placed in the London Society, so he saw his semen for the first time, and he saw small sperms in it, the diagram of which he has made over here. I think this diagram by the optics which were there at that time was brilliant. And this man wrote a letter that, sir, herewith, like if I probably write a paper today, I would write that, well, these are the findings which I'm sending for publication. And in case these findings are there, or please let me know if any improvement could be done, I would be more than glad to correct it. But you know what he wrote? He wrote, I herewith present the findings of my conjugal remains. However disgusting you may find them to be, it may be some kind of a scientific data for us to ponder on. In case you think is it of use, please publish it, or otherwise you can very readily throw it into the waste paper basket. But the truth is, it was published. And for the first time in the world, people came to know from a tailor who wanted to make a microscope to see the threads and the cloth that there is something known as a sperm which may produce a baby. If you go on further, you must have heard of this famous surgeon, John Hunter, the man based on whom is the Hunterian Canal. So John Hunter, this famous surgeon, I don't know if you know about him much, but John Hunter came from a very poor family, and he could not afford anything. In fact, he could not even afford to read and write after the age of 14. So at the age of 18, to earn something, he went to a cousin of his, and this cousin used to work as an anatomist. So the job given to John Hunter at that time was to dig bodies from the graves and dissect them. And during this time, John Hunter dissected so many bodies and turned out and became one of the greatest anatomists. Then he read, he got into medical school, he became a surgeon, he discovered so many things, and he became the John Hunter, the most famous surgeon of United Kingdom at that time. So in 1790, a man came to him with hypospadias. So we know hypospadias is a condition where the opening of the meatus is not at the tip, but on the shaft of the penis. So he came to him that I have this problem and I don't have a child. So he said, well, let me take your semen in a warm syringe. And he took that semen in a warm syringe and placed that semen into the vagina of his wife, and a baby was born. So the first artificial insemination in the world was not done by a gynecologist. It was done by the surgeon of that time. Further on, I'm just taking you through the journey, and I'm going to take you to the journey which is now, and then I'll take you into the future. And I'm telling you, you're going to love it. In case you people are liking it and you want me to tell you the greatest story ever of how a baby was born by artificial insemination donor by a medical student, please type in into your chat box if you have chat boxes over here. I don't know if WebEx has. BIO, bring it on. Just type it on if it is there. If it is not there, I'll just tell you the most interesting story further on. So this is 1884. William Pancoast of Jefferson Medical College, Pennsylvania, one of the most intelligent person at that time, had a big problem. And the problem was he had a microscope and he saw the semen in 1884 and there were no sperms. So when there were no sperms, he didn't know what to do. So he went to a grade class, just like Dr. Lakshmi would come to your class. And in this class of a lot of students, he said there is a problem. And the case is a patient who has no sperms. How can he have a baby? So one cheeky little boy stood up and he said, take my semen and place it. And that was the idea which he did. And from that, at that moment, the semen was taken. The woman at that time was not told because the husband did not want to tell. Later on, of course, the child came to know. And the semen was placed, and the first baby of artificial insemination donor was born. So this is the history of male fertility I'm telling you. Let's go further on. Further on, we go into the 19... excuse me, just tell me one thing. Are you seeing my whole slide or a double slide?
Yeah, double slide. That's what I was about to say, that the slide is small.
One sec. I'll just change it. Yeah. That's what happens with me in WebEx. I told you I'm not used to it. Now it's fine. Great.
No,
now
still it is double only.
It's double still.
Yeah.
How can it be double?
The next slide is also shown.
It is still shown. Just a minute. Just 1 minute.
Okay.
Is it okay now? Yeah. So now what happened is that there was a lady known as Mary Barton. And Mary Barton, just 1 minute, just 1 minute. अमित मैं एक मीटिंग में हूँ, कोई जरूरी बात है? दो या चार. So Mary Barton was a very famous doctor in England. And she wrote a paper in 1935, 37, I think it was. And this paper was a landmark paper. This was a paper where she published that by artificial insemination of donors, she has given birth to over 400 children. And when this paper came out, there were debates in the parliament. There were debates all over. It was really a thing in which it came up to banning it, but it was not banned. It went on. And this was a changing point where people actually believed that if there were no sperms or little sperms, the answer was artificial insemination by a donor. And it is estimated that B.P. Weissner, the husband of Mary Barton, fathered about 350 children. So just imagine a man having 350 children, and the paper was published in British Medical Journal. And this was a turning point. But you know, everything went on like this till magic happened. And the magic was the birth of the first test tube baby. And Louis Brown was born. And the birth of the first test tube baby changed everything. It changed everything because people who could not have children could have children. And you know how many women actually went into getting an IVF done when they never knew it would be successful, just for the trial? There were about 1,000 women who signed in for it. And you think of, if you look at it, the science, and two people who were determined to do this, which has changed the world. So if you look at it, this change of the world with hundreds of women wanting to get it done, and finally having Louis Brown was there. But there was a big problem. The problem was that when the sperms were less, fertilization did not take place. And whenever anything happened, it was not possible. So a lot of people in the world started planning and tried to put the sperm close to the embryo till in 1992, Palermo. I had the chance of meeting him and talking to him. Palermo did the first ICSI in the world in 1992. And I mean, the first birth took place in 1992, though the first ICSI, successful ICSI, was done in 1991. And the beauty which happened is that this changed male fertility. But you know, it stopped the development of male fertility, and women had to unfairly pay a lot of, I mean, she really had to work very hard to get a baby. And this was basically bypassing male fertility. You got one sperm from anywhere and you could have a baby. Now, I'll talk about present day. Do we all know that the sperm count is going down this century? Do we know that the sperm count in the last 50 years has halved? And there is an estimate that in the next 30 years, at the moment, it has not gone below the normal percentile. But if it goes beyond the normal percentile, one of the greatest catastrophes which is going to happen in this world will be male fertility. A lot of new diagnostic tests have come which are beyond routine semen analysis. Antioxidant supplementation, which used to be thought as a placebo, is a very important issue today. Lots of things can be done for azoospermic men. In fact, 70% of azoospermic men can have their own children. And spermatogonial stem cells represent a novel cell source for both reproductive and regenerative medicine. So let's look at these statistics. It's a very interesting thing for all of us to understand. This was a very large review article of which I was a part. And this, in fact, was the male oxidative stress, MOSI terminology, and registration of that terminology in clinical practice for management of idiopathic male infertility. So now let's look at the statistics. Male infertility contributes to about 50% of the total infertility in the world. And it is estimated that the world has 186 million infertile couples, which means that the number of men who are infertile are 90 3 million. Now, out of these, it has been seen that about half, 50%, which means about 46.5 million, are those men who have an unknown reason for infertility, which could be idiopathic. And if you look at the men who have idiopathic, those people are a very large number, up to 37.2 million. So in this world of pollution, in this world of cigarette smoking, in this world of mobiles, radiation, sexually transmitted diseases, food pollution, I would say the pollution in our environment, and more importantly, all those things which are coming into the environment because of humans, it is leading to a decrease in the sperm count. And more importantly, if even you have sperms, the functionality of those sperms is going down. So WHO, we all know, have updated the reference value. But let us understand one small thing, that the semen analysis is simple yet so complex. Dr. Lakshmi, can I know the audience which we have? Because I'll go in accordingly.
We have faculty, but majority of the bulk is formed by the students, our first MBBS students, and then we have faculty from other colleges, postgraduates.
Okay, so they're all physiology postgraduates?
Yeah, physiology and OG.
OBG. Okay.
Yeah.
Okay, fine, great. So this would be relevant to a lot of people, that the WHO parameters which are there, they have been revised, and in 2010, the new ones have come. I'll tell you about that. But in 2010, which is the standard till now, the sperm count is taken as 15 million. And what earlier used to be a morphology of 44% has come to 4%. It does not mean that it is just because there is a different way of looking at sperm by the Kruger's criteria. And the Kruger's criteria gives us a very, very strict methodology of measuring a sperm. So even if 4% of sperms fit into the Kruger's criteria, that is normal. But what we actually need is a motility of total motility of at least 40%. So what is the most important thing is the total motile count. So now what has happened is, the biggest problem in all over the world is that standardization of semen analysis is very poor. So if you look into the physiology of the sperm, you would realize that the sperm is the fastest dividing organelle of the human body. The sperm, you'll be surprised to know that every second we produce about 150,000 sperms. Minutes, sorry. And you'll be surprised to know of the billions of sperm which we produce in a year. And the amount of data which is there, if you calculate in terms of data, whatever is there is the chromosomal data, it will be phenomenal. But then what happens is, this is the most sensitive dividing cell of the human body. And it also needs to be motile. So the most important thing which needs to be done properly is a semen analysis. But then you may have a normal semen analysis, but the problem actually may be the functionality. And the functionality is so important, and that is the reason there are few tests which have come up to see the functionality. So one of them is the sperm DNA integrity. I'm just speak about 3 particular tests. The second is a reactive oxygen species. And the third is a Y chromosome microdeletion screening. So these 3 tests I talked to you why? Because these are clinically very relevant. So the first is DNA fragmentation. Till the time DNA fragmentation came, we used to consider most of the men who had a low sperm count or a normal sperm count who did not get pregnant they didn't know a reason why a pregnancy is not happening or the problem lies with the woman. But when the testing of DNA fragmentation of the sperm came out, something interesting came out. And what interesting came out is that these sensitive sperms have breaks in the DNA strand. And it could lead to unexplained infertility, recurrent pregnancy loss, and poor outcomes in IUI and IV. So sperm DNA fragmentation becomes a very important test for us to know if there is a problem going on in functionality of these sperms. It is just like a set of students in a college. So the class of those students would only be there if they have passed the 12th standard. So if you have 100 students, out of which only 50% have passed their 12th standard, that would functionally not make a good class. So all that you have is 50% of students. Similarly, DNA testing becomes very important. Now I will go into now the most important thing for us to understand today, for every student to understand, because out of these students, I think 50% would be men and boys. So each 50%?
This present batch has equal number of girls and boys.
Great. So I'll tell all the boys first that lifestyle, varicocele are the basic things for us to understand in terms of DNA fragmentation. So excessive alcohol, excessive smoking, drugs, pollution, not adequate sleep, all these things lead to ultimately the DNA fragmentation. In fact, in assisted technology, reproductive technology, in case there is high DNA fragmentation, the results of IVF, of IUI as well as IVF both are poor. But ICSI is better. Why? Because when you inject a sperm into the egg, if it is young, has a phenomenal repairing power to repair the DNA of the sperm. And that's the reason if there is a high DNA fragmentation and the woman is young, the results of ICSI are better. Now, this is how these sperms look. Those which are fragmented do not have halos. Those which are fragmented have halos. This is the kind of halo testing which is there. Then Y chromosome microdeletion. So by doing a PCR of the long arm chain of the Y chromosome in an azoospermic man, you can find out whether there is a deletion in the Y chromosome. Now it's very interesting that in case there is a deletion in the Y chromosome, in the AZA area, no sperm would be found. If you look into the testicle, B area, no sperm would be found. But in C area, you would be able to retrieve 70% of sperms. So this is the way these things happen, and that becomes a very important test. So what is new? What is new is that improved outcomes have been found when antioxidants have been given in male infertility, both in terms of live birth rate and pregnancy rate. So this was a very large global survey where testing and the reason why all this is happening in the world was looked into. And if you see over here in this beautiful picture, this is a picture from somewhere else, that pollution, smoking, drugs, which is environment, diabetes, which is on the rise, cancer, systemic infections, male accessory gland infections, prolonged stasis of spermatozoa, immature sperms, they all lead to oxidative stress on the sperm, which leads to spermatozoal dysfunction, infertility. You need to evaluate the oxidative stress to decrease it. And therefore, these antioxidants once given. Now, which antioxidants need to be given? Vitamin C and vitamin E are the basis. Along with that, folic acid, zinc, selenium, astaxanthin, coenzyme Q, lycopene, and L-carnitine can be given. This needs to be given for at least 2 to 3 months, after which you can find some effect in it. Now, azoospermia, 70% can have their own children. So how many of you guys have seen Vicky donor? How many people have seen Vicky donor? So the whole world thinks that if you don't have a sperm, you need a Vicky donor. In fact, after Vicky donor, I used to get so many calls from so many people that they wanted to donate sperms and they had the best sperm. So I used to ask them, how are you telling me you have the best sperm if somebody came? So he said, I can masturbate 3 times in a day, so I know I have the best sperm. So the world is very interesting. So once Vicky donor came, there used to be a whole story of people wanting to donate sperms. But the interesting thing is that 70% of azoospermic men can have their own sperms. Now I'm going to tell you the secret number 4, which is there presently. So there are 2 types of azoospermia. One is obstructive azoospermia, and the other is non-obstructive azoospermia. So in obstructive azoospermia, what happens is just like vasectomy or an epididymal block, sperms are being produced, but they're not coming out. And in non-obstructive azoospermia, sperm production is not taking place or is deficient. Well, it could be because of radiation, chemotherapy, trauma, genetic, any of these reasons. And therefore, for that reason, there are a lot of procedures which could be done, which we do. And these procedures can be PISA, TISA, RITA, TISE. And I'll just give you a glimpse of the way these procedures are. So what is done is that in case there is obstructive azoospermia, you'd like to take out some sperms which are there in the fullest area of the epididymis. So you probably would put in a needle. I mean, it looks simple because I've done so many, but you need to know the exact place where you need to put a needle blindly with media to be able to get some kind of a aspirate. Now this aspirate in obstructive azoospermia may give you a sperm. Then you may need to take a small biopsy. Now a biopsy is only useful in a condition where you know spermatogenesis is taking place. Because a lot of times spermatogenesis is not taking place. So in non-obstructive azoospermia, normally a small biopsy does not help much. Then there is a situation and a surgery in which we do multiple biopsies for sperm attraction. So what is done is you open the whole testes, and once you open the whole testes, you would take multiple biopsies from different areas, thinking that at least some spermatogenesis may take place. See, I'll just explain to you. The testes in non-obstructive azoospermia is like an apple tree. So there is a tree, only on a few branches you are going to have apples. But how do you know where apples are? You cannot know where apples are. So the only way you can know how apples are, by earlier taking multiple biopsies. But now what we do is, we do not take multiple biopsies. Now we do a procedure known as micro-TC. So in micro-TC, what we do is, in micro-TC, we open up the whole testicle. And once we have opened up the whole testicle, we see the whole seminiferous tubules under a microscope. And under the microscope, we see which are the tubules which are thicker. And those tubules which are thicker, we open up those tubules, take out sperms out of them, and prepare those sperms and do ICSI with those sperms. So we've given children to cancer survivors, we've given children to maturation arrest, we've given children to so many people who could never think they could have children. So this is the way micro-TC is done. So you opened up this testicle, you seeing under a microscope, and under a microscope, you would like to take out sperms from an area which you think would be having thicker seminiferous tubules. I mean, it's just like an apple or an apple tree. And once you have taken these out, these tubules, in the laboratory, these tubules will be stripped. And once these tubules are stripped and the sperms are taken out, these sperms would be injected into the egg, and then human tissue culture would be done so as to get sperms. So this is in male infertility, at the moment, this is the cutting edge technology which is available. So this is at the present moment. This is known as a micro-TC. So this is how it looks under a microscope. If you see under a microscope, these are a few tubules which you think are thicker. And these are the tubules which you would take out under a microscope. And once you have taken them out under a microscope, you can see over here, these are the tubules which will be stripped and sperms would be taken out of them. Now this is a video where I'm showing you of how in a PISA sample, these sperms would look like. You have washed it, there is debris, there are RBCs. And if you look into it, you would find a few sperms. And these are the sperms which need to be picked up. You can see over here, there's a motile sperm. One motile sperm over here. Now this is how we would do an ICSI in these patients. So if you see over here, we're going to pick up the sperm. Looking for the sperm, if you see over here, you'll be able to see a sperm. So you can see a sperm over here. We're going to pick that sperm up. And then this is the egg. You'll have to have the polar body at 6 o'clock position. That should not be injured. You'll inject. You'll aspirate a bit to see you're in the cytoplasm. And then you would inject the sperm. So the trick, the beauty about human beings is we always want to be better versions of ourselves than what we were yesterday. So the version number 2020 is not the same as the version number 2021. And the development of humans takes place just like that. It's just a patient I'd love to talk to you about. A very old patient. Now I think these children are about 12 or 14 years each. Once you retrieve a sperm in obstructive azoospermia, that sperm is as good as an ejaculated sperm in obstructive azoospermia. So it's very important for us to understand that the chances of having a child are very good. So no obstructive azoospermia today in 2021, if they can afford, use a donor sperm because they can have their own children. And the joy of having your own children is something which is very different, which I see every day with my patients. This is another patient with TSE who had children, but this is a very interesting case. Now, this is very interesting because I'm telling you a small story now. This very rich lady came to my clinic and she said, where can I buy the most expensive sperm from? So I asked her, why you are saying this to me? So she said, no, I want to buy the most expensive sperm in the world. I said, why don't you talk to me clearly? Then I realized her son had hypogonadotrophic hypogonadism, diagnosed at the age of, I think, 12 or 16. No treatment was taken. He got married and he had small testicles. His FSH, LH were low, testosterone was very low. And so I told her, I said, well, I do not know if it's the most expensive, but the best sperm will be the sperm of your patient, who incidentally was her son. So we started them on hormones. It's a long time back. I mean, those children are, he has 2 daughters. They're about, I think, 13 years old now. I've had phenomenal, so many babies after that of hypogonadism. So started them on HCG. HCG is equal to LH in the hormone. You are all physiology students, you will understand. So there was no LH, we gave them LH. After giving LH, when the testosterone became normal, you need testosterone as a milieu. It needs to be normal for the seminiferous tubules to produce sperms. So once the testosterone was fine and the testicular size became okay, we started giving them HMG. HMG is FSH and LH. So what you need is FSH for spermatogenesis. So we give FSH. And after about 6 weeks, the testicular size became okay. And about, I think it was 4 months after that, I got a call from the laboratory. Yeah, they have seen these sperms and they were ecstatic. So after that, we did an ICSI. The first ICSI, she did not have children. I mean, she didn't get pregnant. Second ICSI, she had triplets. So we had to reduce them, quadruplets in fact. And we had to, because we transferred 4 in those days, thinking that at least one should stick. We just did not know how it would be. And we finally reduced them. And she had 2 amazing, beautiful daughters. And if you ask me, this is so beautiful. This is a gentleman, a cancer survivor. So he's a technician in a hospital. He's a radiographer, I think. And his father, when he was a young boy, when he developed Hodgkin's lymphoma, or it was non-Hodgkin's, I don't know really, went to their Babaji. So the Babaji said there is one Dr. Advani in Mumbai. So he then told me that he took him to Mumbai. in the train, which he told after he had a grandchild. So when he took him to Mumbai, they sat over there in front of Tata Memorial. Dr. Advani treated him and he became okay. He grew up into a young boy, got married, but had no sperms because of all the chemotherapy. So then he went to the Babaji again. So the Babaji told him there is one doctor known as Dr. Jindal in Meerut. You go to him. He didn't tell me initially, I tell you. He told me after the baby was born. So he came to us. We were very skeptical. This was an old, this is long back. I think this was about 10 years back. These are all old stories I'm telling you about. So we said, okay, we can try. So we did. We opened his testicle. We looked for sperms. We found a few sperms. We did ICSI. We got embryos. We were happy. Then we came to know beta HCG is positive. We were ecstatic. Then we came to know the baby is growing. Then we came to know it's been 3 months. And finally, she gave birth to 2 lovely babies. And let me be honest with you, that was the day that we ourselves felt so complete in the work we're doing. Because we actually felt that we've been able to do what we wanted to, and which we never thought ourselves we'll be able to. So from that day onwards, we decided that we've got to try for all those people who don't have sperms to be able to give their own children. So in the last so many years, there's so many children who have been born that today, if you ask me, one of the mainstays is that 70% of azoospermic men can have their own children. So this is still what is there at present. So now I'm going to talk about the future. Future is very exciting. Very exciting because the world is going in a different direction. In the computer age, you're going into AI. Everything will be replaced soon by AI. The only thing left in humans will be their emotion. So keep it intact. And in medicine, it is going to go into preventive medicine. I mean, why should coronavirus affect a human being? We've discovered vaccine in record time, but why could we not have something that corona does not affect us? I mean, that's the kind of genetics we're going to go into. One of the most powerful lines in the future is going to be genetics. So my dear students, you're doing your MBBS. At the moment, you're in the physiology class. But let me tell you one thing. Medicine in the future would not only mean medicine, surgery, gynecology, and pediatrics. Medicine in the future will be basic research, which will be very powerful. It's very powerful in the West. Let me be honest with you. Departments and value which is given to the basic research is the same as a clinical line. In fact, every clinical line has a basic research. And the most important thing in the future which is going to happen is medicine is going to go into genetics, stem cells, basis, and biotechnology as well. I mean, we need to understand it. So now what is happening is that you have a subset of patients of non-obstructive azoospermia or oligoasthenospermia where you can't get sperms or you get poor sperms. So these are the areas where spermatogonial stem cells, which are present in the testes, can be taken out and they can be either cultured in the lab to make sperms, or they could be transplanted into an animal or a human for them to grow. And it's so exciting at the moment that in mice, it has been done already. Humans are the only ones which are left. So it's an era of biomarkers. Now what happens is if you go through physiology, I mean, you have such an amazing physiology teacher as Dr. Lakshmi with you. So if you ask me, when you go through physiology, you realize that all the metabolites which are formed, a few metabolites are such, if they can be quantified, those metabolites would give you an idea of what is the problem which is lying. And that is leading to genomics, transcriptomics, proteomics, and metabolomics. So this calculation will in the future be able to prevent a lot of problems. Now, I was talking to you about this. This is very interesting. So you get a sperm, you do it, see you get a baby. But supposing there is no sperm, you take the tissue, transplant it into a mouse to get a sperm. You could organ culture it to get a sperm. You could auto-transplant it to get a sperm. If you get spermatogonial stem cells, you could culture them, transplant them to get a sperm. And if you actually just understand, even in the future, from skin biopsy, they could get pluripotent stem cells and make them into sperms, transplant and make them into sperms. I'm talking of sperm because I'm talking of sperm at the moment. But probably this could be done with anything. You have a liver problem, liver transplant is needed. Probably what would be injected would be stem cells. They would be controlled to switch it on and a control to stop it. You have a spinal injury. We all say neurons don't multiply, but there could be something which could be generated from the original stem cells, because what we ultimately come from is one egg and one ova. And there is one embryo with only 2 cells. So all that is built is from them. If we understand the triggering mechanisms of what happens and because of which what happens, this world will be so different to us. And this would be, so I've talked about spermatogonial stem cells, I've spoken about this. So this was in 2011, when in a mouse in Japan, they took out the male germ cell and tissue cultured it, made it into sperms, took those sperms, inseminated mice with those sperms, and got pregnancy. So if this has happened in mice, it should happen in humans. But they have not been able to get the perfect human tissue culture. They have not been able to get the tissue culture methodology of starting and stopping, but it would be there. Now, how many of you have heard about CRISPR? How many of you have heard about CRISPR-Cas9? The magic of the future. Till now, it was very different. Till CRISPR-Cas9 was taken out, it was very different to do gene editing. But just like a sequence is changed by a virus, similarly, they were able to snap, change a sequence in these cells, and done so easily that CRISPR-Cas9 has become one procedure done all over the world. But there are a lot of ethical issues, because if some of you guys want a child like Sachin Tendulkar, you probably in the future would have it if ethically it would be allowed. Well, you've not been able to marry Katrina Kaif, but you want a daughter like Katrina Kaif, so the embryo could be modified for you to have Katrina Kaif. This may happen. There could be only football stars who are CRISPR babies. You could have only cricket stars who are designer babies. But I do not think that would be this way. But I really think that if there are 2 diabetics who want a child, the gene of diabetes could be removed and replaced. If there are 2 thalassemics who want a child, the genes of thalassemia could be taken out and replaced. And this is the way I think the future would be. And I take you into my last slide and something to think about, which will happen probably. When a man and a wife want a baby, the sperm and the oocyte gives the baby. Now 2 men get married. Well, at least it's legal in our country too. Homosexuality, the old rules have been changed. So if 2 men are allowed to get married, till now what happens is they take a donor egg, they take a surrogate, and they have a baby. So they flip the coin, whose sperm will be taken, and one gives the sperm for the first baby or the other gives the sperm for the second baby. But if from a pluripotent stem cell you made an ova, and you took the sperm from one, and you made children, and in the surrogate both had their own baby, wouldn't that be wonderful? And if there are 2 women, one could use her uterus, the other could give her egg. And of course, the sperm could be made out of a pluripotent stem cell for them to have a child, their own child. But the only thing is, they will never be able to have a son. And this is the beauty of the future. I do not know what version of our lives is going to take us into this world, but we will be there. And I love science, and I think in the future is going to be brilliant. Spermatogonial stem cells, mature functional stem cells, differentiation, non-differentiation needs to be clarified. Rapid research is taking place, and the future is going to be beautiful. We gave birth to a genetic male. This was another beautiful story. And this is when we came on the week as the man who gave birth to twins. This man is not me. The man who gave birth to twins was a man who gave birth to twins. So this is the way it happened. And thank you very much. I really appreciate your being over here. And I really love to be there. I hope this would be of some use to you. Thank you.
Thank you so very much, Dr. Jindal, for taking us through a very interesting and remarkable journey, like of past, present, and future of male fertility. Like you gave an interesting anecdote and interesting story of our mythology to the present day estate reproductive techniques. Like you gave an important, nice demonstration, like the videos about the important techniques that you are doing daily, ICSI, TESI, and the PESA, and whatnot, and to the designer babies. I really loved your presentation, and I really appreciate the time and effort that you have taken for our CME. And I'm sure our delegates would have also appreciated it, and they would have loved your presentation. Thank you for being with us this afternoon. Really great. And I'm sure the gynecologists who are from our college and from other colleges who are attending your talk will be definitely sending you mails, and they will get your details from me, and they'll be asking you to give talks in their colleges. So you are because of your center and what work you are doing, you are already on an international map. Now, the south part, this area which was not knowing you, will also be knowing you henceforth. And you'll be definitely our, our OG madam is also attending, and most probably she is going to recommend your center for our PG training program. Thank you.
Thank you very much.
Thank you. Thank you, Dr. Sunil. It was really nice. I really loved your presentation. Thank you.
Thank you very much. Can I leave now, ma'am? Because I just had to rush somewhere.
Yeah, definitely. Yeah,
Okay.
just winding up. Yeah. Jagdish.
I can't.
Good evening to one and all present here. It is my proud privilege to propose the vote of thanks for this August gathering. Our heartful thanks are also due to our Honorable Chancellor, Dr. A.S. Ganeshan and Dr. Anuradha Ganeshan, Director, VMRF Salem, as they are pillars of support and strength of all of us. My sincere thanks to Dr. P.F. Katur, Dean AVMC and H, a dynamic leader who has been always guiding us. We are really honored and thankful to our today's speaker, Dr. Sunil Kumar Jindal, Scientific Director and Chief Endolaparoscopic Surgeon and Male Infertility Specialist, Jindal Hospital and Test Tube Baby Center, Meerut. And Dr. Shashikala R, Reproductive Medicine Consultant, and Dr. Sebanti Das, Chief Embryologist and Managing Director, Srishti Assisted Fertility and Advanced Laparoscopic Center, Pondicherry, for taking out their precious time and sharing their wisdom and knowledge with us. I would like to thank Dr. M. Gopinath, Associate Professor, and Dr. Jyoti Mari Fiula, Assistant Professor, both from the Department of Physiology, AVMC and H. I would also like to express my gratitude to Dr. Vishnu Bhatt, Director Research and Dean HP, Dr. V.N. Mahalakshmi, MS Dr. K. Joyasingh, VP Academic, Dr. T. Rajan, and VP Student Affairs, Dr. D. Arunachalam, for their guidance and support. I would be failing in my duty if I would not thank all the delegates from various parts of India. Thank you all for your participation. I thank our account section, audio-visual team, graphic designer, and computer operator for their contribution in conducting this CME. Last but not the least, students of our college and other colleges deserve to be thanked for their support and participation as well. Thank you one and all.